Welcome to day 2 of the Preconception Coin Show Your Love Initiative Future Forward National Convening on Equity-Centered Women's Wellness. This is the second of the 3-day virtual conference, and across this conference, we will build energy, create conversations, share information and learning, and chart the course forward in preconception health. Thank you again to all who joined yesterday. I'm Jessica, and I'm so excited to be here.
Hello, my name is Kennedy, and I'm incredibly excited to be here as well. I'll be co-hosting with Jessica today.
Yes, we would also like to thank Ana Cabello de la Garza, Eilish Neely, and Shamika Tumblin for supporting the conference as fellow Show Your Love squad. We're excited to have Rio Holiday join us today again. Rio Holiday is our graphic facilitator who will be listening to the conference session and taking live graphic notes to beautifully capture our insights. If you joined us yesterday, you're in for a treat. If you experience technical difficulties, be sure to email Catherine Bryan, and you can check the chat for Catherine's email.
There are a few ways you can engage with the speakers and others during this conference via chat and the small breakout groups. And please share key points via social media. We're going to have an evaluation survey each day, so please take a minute to fill that out. It's really important to us. We also want to acknowledge that this land is Indigenous land and was first inhabited by the first peoples of this land, our American Indian people, and this land was stolen from them. And we want to offer gratitude for the living legacy of those communities and commit to honoring this land and their contributions to it from the past, present, and future. So in the chat, we just want to have you share your name and where you're from. But now we're going to kick off the first session, which is going to be measuring change, preconception health, and women's wellness indicators. So during this session, we will hear more about the updated indicators and strategies for measurement of preconception health at the clinical, state, and federal levels. We will be monitoring the chat and we'll save time for open discussion at the end. And we'd like to have Bella introduce herself. Isabel Morgan will be the facilitator for this session.
Thank you, Kennedy, and thank you, Jessica. Welcome, everyone. So my name is Isabel Morgan, and I am a doctoral student at UNC Chapel Hill in the Department of Maternal and Child Health. I'm also minoring in epidemiology. And outside of UNC, I have the pleasure of working with phenomenal women like Kennedy and folks at the National Birth Equity Collaborative as part of the Birth Equity Research Scholars Program. So we hope that you were able to tune into the opening sessions yesterday. As this virtual summit is focused on looking ahead and moving forward, today in this session, you'll be hearing panelists share insights on emerging opportunities for data measurement and management. I think it's important to highlight and reiterate some of what was shared yesterday in the opening sessions to help with level setting for this specific panel discussion. The conference organizers acknowledge that preconception health language is limiting, particularly in that the original conceptualization of the preconception health framework focuses primarily on individual level behaviors, which can detract from structural factors and systems that impact one's overall health and wellness. In fact, there have been efforts to move beyond the preconception health framework. So for example, in February of this year, Dr. Christine Dellendorf and colleagues, including Monica Simpson of Sister Song, Miriam Young, formerly of the National Asian Pacific American Women's Forum, and Dr. Joy Creer-Perry of the National Birth Equity Collaborative, along with other contributors, published a call to action to center reproductive and sexual health equity, and that was published in Obstetrics and Gynecology. Further, yesterday, as panelists were sharing the amazing work that they're doing, they also described their expansive visions for health and wellness. And we heard the importance of gender affirming care. So in this session, we also want to uplift the importance of gender inclusive language. I do want us to acknowledge too that we come from different backgrounds and have different affiliations, which might impact the language that we're using. So I want us to try to hold all of those things in this session. So we're aiming to hold the discussion between panelists for about 45 minutes. We'll reserve 10 to 15 minutes for a Q&A towards the end. We welcome your questions and reflections. And if we have access to the Q&A feature, we'd actually prefer for you to use that feature so we can keep track of those questions. So with that framing, I will now introduce our wonderful panelists. We have Dr. Ekwatasi Okoro, who is a lieutenant commander in the United States Public Health Service and is currently the team lead for the Maternal and Child Health Epidemiology Program in the Division of Reproductive Health at the Centers for Disease Control and Prevention. We're joined by Sarah McCracken, who works as the State Systems Development Initiative Project Coordinator for the Women's and Children's Health Section in the North Carolina Division of Public Health. We're also joined by Dr. Deidre Quinn, who's an Advanced Research Fellow in Women's Health with the Center for Health Equity, Research and Promotion at the VA Pittsburgh Healthcare System. Dr. Quinn is also an adjunct instructor of medicine in the Division of Internal Medicine at the University of Pittsburgh. And last but certainly not least, Megan Williams, who is a research associate at the Collaborative for Maternal and Infant Health at UNC Chapel Hill. So welcome panelists, and thank you all for joining us today. I also want to make space for Rio. So you had a brief introduction to Rio, but Rio, if you don't mind introducing yourself and sharing with us how you'll be participating in today's session.
Absolutely. Hello, everyone. It's so lovely to see all your faces again today. My name is Rio Holiday. I'm a graphic recorder based in San Francisco on Ohlone land. My background is in public health, and I will be doing 3 things during this session and the sessions today. I will be listening, synthesizing for key themes and quotes, and then the part that you'll see at the end, I'll replace my camera with my iPad screen, and you can see the documentation using both words and images of what the conversation was about. This is a reflection of your conversation, so I invite changes, additions, and interactions. Thank you, Isabel.
Wonderful. Thank you, Rio. We can't wait to that what you're going to show us at the end of the session. So why don't we get started, have our panelists join us. It would be helpful if we provide an overview of what measures, when we talk about preconception health, when we're talking about indicators related to health prior to pregnancy, what's currently available at the clinical level, at the state level, and the federal level. So why don't we start with you, Dr. Okoro?
Sure, thank you. Thanks again for this opportunity. I'm just going to provide a very, very high level view, and I'm not going to get into any specific indicators because, again, the point of this is not for us to continue to talk about what's been done, but how can we move forward? So in general, work around addressing preconception indicators has been going on for about 15 years. The first effort occurred in 2006 when the Select Panel on Preconception Care work group published 10 recommendations promoting preconception health and health care for women of reproductive age. And then following that in 2007, the same panel convened a voluntary group of maternal and child health program leaders and epidemiologists from 7 states to basically help them develop a 45 core state preconception health indicators. The point of this work group with the additional stakeholders was to assess the usefulness of these indicators and whether these lists needed to be condensed further, because 45 is a lot for anybody to deal with, that could help states better set priorities and implement system changes that would lead to improvement in the health of women of reproductive age, especially during the preconception and interception periods. As they were going through this evaluation and assessing, they actually realized that very few of these indicators focused on preconception care that targeted healthcare system change. And I think that's something that Ms. Morgan mentioned earlier, that there's some limitations around systems healthcare change. So in 2016, they decided to have another meeting to talking about consensus indicators that will focus on preconception wellness. So we started with preconception health, then we moved to preconception care, and then now we started to think about preconception wellness. And basically the point of this newest piece of it was to kind of think about quality metrics that will help improve healthcare delivery within the healthcare systems. And the hope is that with the inclusion of these wellness indicators, we will be able to assess issues at the initial prenatal care visits, that we'll be able to do quality improvement tools, and be able to make sure that the healthcare system is performing to really help women optimize their health status prior to pregnancy. Because we're a working group and we always want to do something to improve. Again, we met in 2018 as a group, this time again in partnership with the CDC group, to further narrow all these indicators. So we started with the 45, that went down to 10, but again, that was for the healthcare indicators. So in 2018, we decided to focus on the preconception care and the preconception wellness piece of it, which was something that we hadn't done. And during that effort, not only did we just think about what was available, but we also wanted to make sure that they were in alignment with the Healthy People 2020 objectives. We also wanted to make sure they were in alignment with the National Quality Forum measures, and really trying to make sure that as we're recommending these indicators, these are things that states could have access to, the types of data. So whether it was BRFSS data or PRAMS data, making sure that these were surveillance opportunities that state could really monitor the health of their population. During this latest iteration of our assessment, we actually found 80 potential preconception care indicators. And after doing additional evaluation, speaking to stakeholders, consulting with subject matter experts, the list was narrowed down to 30 that again focus on preconception care. And that's kind of like where we are at this point as of the literature, in terms of we now have these 30 indicators that prior to COVID, the hope was that we were going to start trying to really go out into the states and help them think through of how could they use it. Could this 30, similarly for the preconception health that was narrowed down from 45 to 10, could this list of 30 for care be narrowed down to a more reasonable numbers that states could use to keep track of their healthcare? Their population. So that is basically a quick overview. I saw somewhere in the chat that somebody was asking about access to the numbers. Some of the papers that were offered prior to the session has the full listing, and we can definitely send a link again out to those papers where they actually they have the tables where they talk about each of the individual indicators in more detail. So I will stop there, Ms. Morgan, and let me know if we need to add anything else.
That was wonderful. Thank you, Dr. Ekwitasi. Absolutely. It's really lovely to hear about that transition from care to health to wellness and how we're thinking about overall health and wellness for people prior to pregnancy. I do want to bring in Dr. Quinn and Sarah to talk about what these indicators look like at the VA, but also at the state level.
Sure, so I can start sharing some experience we had attempting to access these indicators. So we recently completed a study in the VA, so one large national health system, and we were trying to access the 9 preconception wellness indicators that Dr. Okoro just mentioned. We had 2 goals with the study. The first was to see if these indicators are actually practically accessible in the health record, like is this actually something a health system could use to assess preconception wellness. And then second, we wanted to get a sort of preliminary assessment of how our patients within the VA system were doing in terms of preconception wellness. So we encountered a variety of snafus, the first of which was that we were only able to access 8 of the 9 indicators in our large national data set because pregnancy intention is not a variable that's collected by VA. So that's one of the 9 preconception wellness measures, and we weren't able to assess it. But the other 8 we were. Another slight snafu that we had is that the indicators that Dr. Okoro mentioned, they were designed to be assessed at the first prenatal care visit. But because within VA, prenatal care is outsourced to the community rather than provided in-house, so we're relying on external medical records to give us that first prenatal visit. So for some of them, we weren't necessarily assessing it at the first prenatal care visit. We looked further backward in the health record, but we were able to see 8 of the 9. And we found really a lot of inconsistency in the documentation of routine screenings, which was a little surprising to us. So screening for things like tobacco use and depression, screenings that we think of as being very standard in primary care. but just a lot of inconsistency in the documentation of them and how they're recorded and by whom they're recorded and when. And that really made it a little bit difficult to draw conclusions about the pre-pregnancy wellness of our population, because just because it's not documented doesn't mean the screening didn't occur. We don't want to make, wide assumptions about the fact that we might not be asking women these questions, but we don't have a record of them. We also have within VA the possibility that our patients may have outside primary care or specialty care providers in addition to their VA providers. So some of these indicators aren't as easy to access from the health record as it might seem like they would be, which was an adventure. I mean, there are always many adventures when you're going through large national data, but just not seeing exactly what we expected just in the health record. And our study obviously was retrospective. So we were starting with patients who had a pregnancy, and then we started with the date of that pregnancy outcome. We counted backwards to sort of get to their last menstrual period, and then backwards again to capture a pre-pregnancy timeframe, which did give us it was a good way to use the administrative data. But thinking about these indicators, there are definitely challenges, particularly if you wanted to think about real-time assessment by providers. I would say that these indicators were not as easily accessible as you might hope, at least in our national data. So that was our experience. But I know Megan has a slightly different experience, I think.
Yeah, I can go ahead and jump in. I also worked on a very similar study as Dr. Quinn. We actually looked at 2 health systems within the same state and tried to compare, really where we looked to see whether we could access the preconception health indicators in both of those electronic health records as well. And we found a very similar, we came to a very similar result as Dr. Quinn did. We had quite a bit of missing data. We had one indicator that we could not access either. And what we ended up doing, it was also for the pregnancy intention indicator, we ended up using a surrogate indicator because we felt that we might be able to get some data that would kind of be maybe even a better substitute for that intention indicator. So we used family planning counseling as our surrogate measure for that indicator. And so we got some data for that, but we had trouble also with the tobacco use indicator, which, as Dr. Quinn mentioned, is usually a really basic screening that you give to every patient. One of our health systems that we were looking at did not have any historical data for the tobacco use indicator. So it was like a real-time field that changed each time the patient was seen. One of the other problems we had as well was we were looking retrospectively. So when a patient came in during the pregnancy for their pregnancy care, we didn't necessarily have any of the information prior to that pregnancy. Oftentimes their medical record would kind of show up as a PDF that was then filed, in somewhere in the medical record, but it wasn't queryable in any way. So we couldn't, oftentimes we had no data from the preconception period that we could pull from. And so we were using kind of the first pregnancy visit as our preconception health indicator. Another thing that we found was that some of the screenings and other information that we would have liked to have been able to query perhaps was in a notes field or some other place where it really wasn't easily accessible or usable. And like Dr. Quinn, we suspected that a lot of this care was being provided. It just wasn't being documented well in the medical record. And so if it's not there practically for the clinician to be able to use in a visit, it's not really serving the purpose that we would like it to.
Thank you, Megan, and thank you, Dr. Quinn. We're seeing in the chat that there's questions about the preconception care, preconception health indicators. So I think we might want to take a step back. So if panelists, if you can provide some more insights on what specific indicators, you've talked about the ones that you've had challenges with, but giving an overview of what the indicators are, that might be helpful for the audience.
Sure, so I can share what the 9 preconception wellness measures were from the frame paper that we were basing our work on. And I think that's the same work that Megan was just discussing. So the 9 indicators are pregnancy intention, access to care, preconception multivitamin with folic acid use, tobacco avoidance, absence of uncontrolled depression, healthy weight, absence of sexually transmitted infections, optimal glycemic control in women who have pre-gestational diabetes, and then teratogenic medication avoidance. So you can see that there are sort of a range of factors that would be found in the health records. Some, like we said, in a screening interaction between a provider and a patient, some coming directly from lab data, at least in our case, the STI testing and teratogenic medication avoidance was coming from lab data. So you're talking about, at least in our situation, combining multiple sources of data to get at these 9 indicators.
Thank you, Dr. Quinn. Did other panelists want to add specific details related to the preconception care indicators?
I'll just add that as part of the point, we were trying to determine how many of the people in the clinics were getting pregnancy intention, were being asked about pregnancy intention. I mean, that was the whole point of the coin, is to create a way to make sure that people were being asked about that. And in our clinics, we had 3. It was really hard to capture that data. That there was not a data element that was already in their management information system. They had to either put in a dummy code, and that was cumbersome, and it just didn't work well. And even MAHEC, which Megan worked with, they did a better job of capturing it, but it had a low percentage of women who ended up being asked about pregnancy intention, even though they had lots of training on the screening tools. So again, it goes back to what Megan and Dr. Quinn were saying. It may be that they were asked, it just didn't get put in the notes. If it's not in the notes, it didn't happen. I mean, when you're looking for data. So yeah, it's more of a, if we really want to know this, then we've got to come up with a better way to capture. And then
Thank
the
you,
other
Sarah.
thing is when we were, are you going to jump to like the surveillance measures that are different from the clinical indicators? Is that?
Yes, please jump in.
And again, I feel like we've got the expert on here, so please take over for anything that I say wrong. But when they condensed them down into the set of 10, it's really from behavioral risk factor surveillance system and the pregnancy risk assessment monitoring system, BRFSS and PRAMS, and it's current smoking, depression, diabetes, folic acid intake, heavy alcohol consumption, hypertension, normal weight, physical activity, postpartum use of a most or moderately effective method of contraception, and unwanted pregnancy. So they correlate with the clinical indicators, but aren't exactly the same. And I will say that for North Carolina, you know, we have BRFS and PRAMS data with the normal caveats or pitfalls of those, that response rates vary, that so if we want to compare across the nation, that's not always possible because some states will have their estimates included or not included in national hospitals if they didn't meet their thresholds. You have to be mindful of confidence intervals and small sample sizes, particularly among subgroups, that you really will probably have to combine multiple years in order to get race or ethnic specific subgroups. And you know, with the weighting, that's not something that just anybody can do. You kind of have to make sure you've got some statistical software that can be done. It has to be done nationally and then brought back to the state. So it's just not as simple to get when on a practical matter, county level data. We're not for some of these measures, but that's what our state wants. We have 100 counties, they want county level data. And it's hard to say, sorry, we don't have a sample size that can do that.
Thank you, Sarah. And we heard most of what you shared. I did want to note that your audio is breaking up a little bit, so you're coming in and out. I don't know if that's something that you can address on your end. But I think it's important for the audience to keep these in mind as the panelists were sharing the different challenges that they've experienced at the federal level, at the state level, and in clinical settings on trying to actually measure, like capture these preconception care, wellness, and health indicators across the different settings. When we move into the discussion, talking about what needs to be changed and where there's movement, I would like for y'all to keep these challenges in mind. So moving to our next question, we know that there are racial and ethnic health inequities that Black women and other people of color with the capacity or the desire for pregnancy experience really across the life course. And there's more evidence that's demonstrating the impact of structural determinants, including structural racism, on racial inequities and reproductive and maternal health. So we've seen some really groundbreaking research on structural racism in preterm birth, on low birth weight, even on pregnancy-related mortality. So as we acknowledge systems and structures that impact health outcomes and well-being, how might we contextualize our data so that we're avoiding perpetuating limiting narratives about populations who are most burdened by health inequities? And anyone can address this question.
I'll take a stab at it. I think one of the things, at least from a national level, that we're trying to be more mindful of, and I think there's been more and more conversations about it in this concept of decolonizing data. I think one of the important areas, and especially we've seen this when we do deal with data related to Indigenous people, where the reference group tends to always be the white population, which is not always accurate because for example, with the Indigenous people, those that are in the urban setting are very different from those that live on the reservation. And if you're using white in general as the comparison group, you're not really comparing. It's important to compare urban to urban and those on reservation to those on reservation. And I think the same could matter for all of the different populations. Like, when we talk about Black women, you have those that are from Caribbeans, those are from Africa, those that have been in the United States for generations, and comparing the differences between that group would provide more richness in the data than necessarily always using white as the reference. And I know that's something that there's been more and more conversations about. I will say that it's an ongoing process, and I know we're specifically talking about preconception care. And as we're thinking about the indicators in general, and just think about what Dr. Quinn and Dr. Williams referred to, is how do we get, because the key is we only have good data depending on how it's collected. So how do we get more in buy-in at the lowest level, at the community level, at the hospital level, so that way by the time either we're looking at it from BRFSS or PRAMS, it's something that's really useful, not only to the overall population, but to the specific groups and making comparisons. It's a very complicated process, but I think the key is that we as researchers who are interested in this have to continue to advocate for the desire to make sure the data at all levels is collected as appropriately as possible.
Thank you, Dr. Okoro.
I was just
Are
going
there
to say,
other reflections?
add on to that a little bit. I think this probably is something that we all, as researchers, are very well aware of, but just something to be constantly thinking about, the context of the data, where exactly it came from, and how, and as Dr. Okoro said, how it was collected. So in the VA, for example, race and ethnicity data is self-reported by patients when they first enroll in VA care, when they first enter the system, it's self-reported. So we do, but as always, there are limitations in the categories that are selected in our sort of administrative pot of data, but it is self-reported. But in other situations, you might have data that race being recorded by an external observer, an interviewer, or an intake person at a hospital system. So just thinking, when you're thinking about the data, making sure you understand how it was collected, where it came from, and how that might be impacting the data itself, what biases might be at play based on how it was initially recorded, and who we do or don't have information about. I think it's just something we are constantly keeping in mind, although I don't have a necessarily ideal answer or solution for that problem, but just something to always be thinking about when we're thinking about this data.
And I apologize for internet being wonky, but one thing in addition to that with PRAMS data especially, once the baby's born and you're asking a mom questions, a birthing person about questions about their child, it's a lot. Recall bias changes things when you have a baby in your arms, and that's just something to keep in mind as well.
Thank you, Sarah. I intentionally asked that question. I know it's tricky for each of you because of what's the data that are available, right? So there's the preconception care, wellness, and health indicators. They're focused on individual level behaviors, right? But it's about, when we think, with that being a limitation, us being very cognizant of how we can contextualize those data. So we don't have all of the answers, at least naming that this is a limitation, at least naming that these individual level behaviors, that they occur within a context, within these larger systems and structures, until we're able to push and advocate for better, more comprehensive data being collected, either through BRFIS, through PRAMs, and through other data systems. Thank you. So now thinking about the implications of these data, how have data on individuals' health prior to pregnancy been leveraged to inform clinical care, to inform policy, and to inform funding decisions?
I would just make a comment that as far as clinical care goes, I think one of the findings that we had was that it would be pretty difficult for it to impact how clinical care is being provided, because we had so many access issues in the EHR. And so I guess I would make the argument that we need to make them more accessible in order for us to be able to use it more adequately in the clinical setting.
I think some of the conclusions we drew very similar, that it would be hard to use these indicators to immediately impact change. But our thinking, at least in the VA, based on our findings, was that there maybe were some sort of low-hanging fruit type things that we could do more easily. So one of the things that we found was that we had a very low, in women who had pregestational diabetes, we had very low recorded HbA1c, hemoglobin A1c values for those women. And that we know that these women are being assessed, they're in primary care, we know that they're receiving treatment for their existing diabetes, and somehow we're just not getting the values easily accessible. So maybe a primary care reminder, what we've proposed is some sort of very basic clinical reminders that would pop up as part of our EHR that would enable providers to just make sure that they're capturing some of these key screenings. And maybe it might feel redundant or they've asked it before, but it would just be a quick, oh, you don't see it in front of you? Ask the question again. And there's always, the concern about adding burden to providers who have a very short period of time with a patient and many questions to ask, many things to consider, but that there are probably some pretty simple, at least in the clinical context, some pretty simple ways that we could leverage these data a little bit. Now, making that actually happen in the clinical setting is an entirely different set of processes, but I do think we felt at the end of our study that there were some maybe easier, small, like clinic level policy changes that could happen, whether maybe not at the system level, but at the clinic level.
I would just add that, the question was how has it, and I think that that's the hard question. I mean, our hope was and is still that the more we talk about these indicators and try to get them used, even despite all of their limitations, that it will help us to continue to keep it in conversation about the limitations of them and how do we need to move forward. Because, one of the things that we realized as we were doing all of our iterations is that there's so many areas where there's a gap that there are no indicators for. In the next couple of years, we're going to have, there's nothing about any kind of weird COVID-19 based issue and how's that going to play a role. So our hope was that the more we use them, then, maybe it doesn't change policy quickly, but if it affects maybe how healthy people metrics are used and decided upon, or how some of the national quality forum indicators are decided, in making sure that all these things are speaking together and they're not working against each other. I think that's the hope that we would have, that it makes more sense. And another area that we are really interested in, and it's kind of related to this, is the whole idea of severe maternal morbidity, which is slowly, there's the algorithm that's been set up by CDC. And the hope is that's the indicators could potentially feed into that, because if you know where women are at the beginning, and as they go through their pregnancy and they have morbidity, you could have some way of trying to keep track of it. So I think we're at kind of like at the cusp of getting to the place where all of these things will eventually work together. And I think these kind of forums allows us, not only the panelists, but those that are in the audience, for us to think collectively together. Like in my area, what can I be doing to try to make sure that all of these things come together? Because our goal is we want to improve health, and what role can I play that helps the overall picture? So it's a hope. We're not quite there yet, but I think that there's chance that something will change.
Thank you. And thinking about the challenges that panelists have shared related to these indicators, I'm wondering about the feedback loops that exist. So when they're experiencing challenges at the clinical level, experiencing challenges at the state level with accessing and measuring these indicators, what sort of supports are available? And if not available, what supports would you all need to be able to improve upon accessing these indicators?
I think Megan and I, we spoke offline about this before, but we both had one thought that what we really want to see is a universal electronic health record, that is what would enable us to more easily access these sorts of data points, and that something like that would solve a lot of our problems in terms of patients who seek care in multiple environments, or through receive care in different locations or from different sorts of providers and different systems. That some sort of universal record would make accessing these sorts of things much easier. I'm not sure how we do that, but I think that's my pie in the sky wish for support, would be a universal health record.
To kind of piggyback on that, I think it's important for us to always kind of keep in mind the fact that we, especially the sites that we studied in North Carolina, that we're dealing with an insurance situation that's really precarious for a lot of people, that oftentimes they're eligible for Medicaid while they're pregnant. And so, because the poverty line, the eligibility standard is a lot higher, the income can be a lot higher for them to be eligible for Medicaid. But then as soon as they're not pregnant, as soon as they have the baby, within 60 days, they're no longer eligible for Medicaid. And so we have the situation where folks that are of low income, at least in North Carolina, have essentially no access to medical care, or they have access to sort of safety net providers. And so they're kind of cycling in and out of the healthcare system with their pregnancies. And so it's really difficult to provide care during those non-pregnant periods, but it's certainly difficult to manage that data and to figure out what those indicators are for any particular person.
Sarah, Dr. Okoro, do you also have reflections when you think about moving the data measurement and analysis forward? What would be helpful for you all, or emerging areas of research that you're looking into currently?
Well, in North Carolina, we have developed a perinatal health, and of course, preconception health is just one part of that, an important part, but just one part. And so we're trying to incorporate indicators that we really can look at more systems level than just the individual. And it's just so hard. So I'm looking at researchers and people like Isabel and Kennedy and others to really lead us in that direction, because for so long we've done it more just let's fix this problem instead of having people well to begin with. As a former director of NCH in North Carolina, I always said the most important prenatal care visit is the one that most people don't get, and that's that preconception health visit. And it can't just come down to a visit. It's got to be, the whole life course and all of that. Sarah said in a comment earlier about, Oklahoma, making sure that when we did the human-centered design to try to figure out what type of tool would work well in clinics to help people answer questions about their healthcare that day and how they were ready or not ready yet for pregnancy. It really does come to, we've got to include the community more and more and more. We can't just think that we've got it. I was intrigued, and I can't wait to learn more about the framework. I've got it pulled up here somewhere that was mentioned earlier in the week. The second, I don't want to get the wrong name. The creation of the cycle to respectful care is what it boils down to, and making sure that in our research we were also including the people that hearing the voices of everybody. I mean, that's what this whole last 2 days has been about. It's the stories, it's hearing the voices of the people that we aren't used to hearing from, and that is important in data as well as in qualitative things as well. I'm not saying that very well. Others join in on that, but it's just, it doesn't matter what data we are collecting if the biases and the type of care that we're giving don't help with that. It doesn't really matter what the data collects.
I'm just gonna piggyback on that. I think that's a really great point. One of our partners with Massachusetts, one of my colleagues, recently Massachusetts developed a racial equity roadmap in which they really not only started internally among their health department about how they view race and racism, but how does their data look at race in an appropriate way. And I think the more at all levels we do the same kind of activity and understanding how are we, either at the national level, the community level, how are we collecting the data and are we being mindful of the voices, I think again that we will eventually, we didn't get here overnight, so we're not going to solve it overnight. But I think the key is, are we moving in that direction? I think that's you were talking about a framework, and that's why that came to my mind. Is they also developed a framework which is specifically around racial equity, and it's around racial equity in data. So they looked at some of their specific maternal child health programs, and I'll make sure I put the link in the chat for those who are interested in checking it out, where whether it was their EDI program or the McBee program, where they looked at how are we collecting our data and how can we collect it more in a racial equitable manner. And I think the more we do that, eventually some of these, it's not gonna, most of the indicators are based on the two data systems, because again, those are the data systems we have. I think one of the other pieces of inclusion is how do we bring in stakeholder data? How do we bring in community-based data, and how can they also help inform this work? But again, it's really hard because it's not something that we all are used to. We kind of stay in our lane and we kind of do our work. But I think all of these things can help us as we try to think about what are the indicators. And maybe we could have different types of indicators. Like these are the federal level based indicators for these many preconception issues. And these are the ones that are based from the community, or you know what I'm saying? So just trying to figure out how do we get it all together is really, I think, an important piece of us moving forward.
And I think we are moving forward, because when we came up back in 2008, 2009, I was part of that initial states group to come up with the preconception health indicators. We weren't asking questions in the same way. We weren't talking about racism. We were talking about institutional racism. At least we're now talking about it. We're not there yet. We've got a long ways to go, but at least the questions are being brought up.
Thank you all. I really appreciate the way the discussion has moved, because I think that these are important elements. So what I'm hearing is being very clear that when we're capturing data on race, we're clear about what exactly we're doing. We're using race, understanding it's a construct, a social construct, and it's sort of a proxy for interpersonal and structural racism. That also we're cognizant of who is participating in developing these indicators. So having diverse groups of stakeholders present, and understanding what these really look like at the community level and how people are conceptualizing and interpreting these indicators, if they make sense, for folks who are actually seeking care. I want to point out a resource that we have linked to. There's a couple of resources that folks have shared. They've talked about the Cycle to Respectful Maternity Care that was developed by Carmen Green and other colleagues at the National Birth Equity Collaborative. I also want to mention the Do No Harm Guide that was published by the Urban Institute on applying equity awareness and data visualization. But I think their tips are more broader than data visualization. I think how we're talking and engaging in research in general. So one of the tips that was mentioned, Dr. Okoro reference related to our reference group. Why are we using white as our reference group? And being cognizant of being very clear about why we're using that are as a reference group. Even in the surveys, they've listed or noted if we have white as the first racial category listed, why are we doing that? Is it because we see white as default? So this is important for each of us to constantly be thinking about ways that we can decolonize our own minds and decolonize our research practices, that we're thinking about the frameworks that we're using to guide our work and also our values. We don't have those conversations enough as to what are our personal values and how do they impact the research that we're engaged in and how we're conducting research. I see that we have 15 minutes left. I want to bring in Rio to share with us what you've been able to capture so far.
Sure. So you can see my screen. It's a little blurry likely, and I believe I'm going to be spotlit in just a moment. And I can highlight a few of the big themes that I was hearing. And so first, we started with this level setting and reminders that the preconception language is limiting. We need to be talking about systems and structures, center women, and also focus on gender affirming care. Then we got into talking a bit about what the indicators include, some of the challenges, how we're leveraging indicators. And then the meat of this conversation that I've heard is really around what's in the middle, structural racism and decolonizing data. And once we started talking about the supports that were needed, we also started flowing into how to hear the voices of those we're serving in the data collection, in the design of research, in the interpretation, in the sharing of data. And so I will let folks look at this for however long they want to, and pass it back to you, Isabel.
Thank you, Rio. This is really wonderful. So again, we are going to turn it over to questions, accept questions from the audience soon. I don't see any in the Q&A feature. If there's others that were captured in the chat, I'm hoping that folks on the organizing team can help pull those out. But for panelists, we're going to close out soon before we jump to question. Oh, there's a bunch in the chat. Okay, thank you, Sarah. If you don't mind helping me pull those out, the questions. I do want panelists to offer some closing remarks before we jump to Q&A, either describing what we haven't covered that you wanted us to make sure that we covered today, or what you want the audience to leave with from this discussion. Sarah, would you like to start?
Yes, I'll leave hopeful. It's been a tough week, y'all, for lots of reasons. Women's health care being one of the big things, but I do think I just appreciate the different organizations that are really working hard to make the data more representative, more useful, and it's pushing people out of their comfort zone, which we need to be. That's how we're going to get to move forward. We do need to increase sample sizes for some things. That's always just a limitation of some of the data, but we just got to be able to ask better questions of the right people and involve the people that we need to involve. And I'm not saying that very well, but I'm thankful for all the new information that is coming out, and just keep it coming.
Thank you, Sarah. Megan?
Yeah, I guess I would just kind of reemphasize some of the things I said earlier, in that the EHR is kind of a blessing and a curse, right? Like there's so much promise with this idea that we have all of this information available at our fingertips, but the practicality of using it in a clinical setting is sort of mixed, right? I know a lot of providers really don't enjoy having to enter data as they're working with a patient. They'd much rather be with that patient than be with the screen of a computer. So I guess creative ways on how we might integrate the EHR in perhaps a different way is something that we could look at in the future. One recommendation that I've heard is some sort of data mining in the notes field, perhaps, so that we can create queryable data from that note section, perhaps, because a lot of the good clinical information is captured there. So I guess I would just encourage us as a healthcare system to push ourselves forward and kind of using the EHR in a more practically useful way.
Thank you. Dr. Quinn?
Sure. First, I just want to echo what Sarah said, that I really am grateful for spaces like this kind of forum that really gives us an opportunity to step outside our just purely research bubble and think about not just the work that we've done, but how does it impact policy? How might it impact practice? Who are we actually serving? Who are we involving? That these spaces like this conference, this forum are just, I think, really great. And I'm very grateful to have been a part of it, so thank you. But then also, this was a theme that was echoed repeatedly yesterday, and I'm going to say it again, that it's really important to me to not lose sight of the fact that what we're talking about when we talk about preconception health and preconception wellness, we're really talking about a person's whole health. And that a lot of the work that we've been able to do has been retrospective. So we start with a person who's already had a pregnancy and we work backwards to explore their health beforehand, but that the goal would be to be able to use all of these measures to improve health in real time, right? Not just to describe the health that has already occurred, good or bad. And that to do that in a clinical setting, I think it's really about getting a message. It's not just to patients. I think we put a lot of burden on patients. Are you doing the right things? Are you, and it's so much more than individual behaviors that impact health. And so getting a message out to providers and to broader systems, as well as to patients, that the care we provide or the care that we seek for ourselves or for others in our families today really has an impact on tomorrow. And so that really deepening this understanding that improving quality and equity in health and in healthcare is a life course question. It's not about this one particular period that we focus on. We're talking about preconception, pre-pregnancy, but that really healthcare across the life course is the underlying sort of ultimate goal, improving across healthcare across the board. And so that when we talk about preconception, let's not forget that what we're really talking about is the whole health of the pregnant person, long before they ever do or don't become pregnant.
Thank you, Dr. Quinn. And I think that's important too for us to keep in mind that we haven't mentioned this yet on this during this session, that preconception overlaps with postpartum for certain birthing individuals. We haven't had that discussion, and that's important to bring into this space. Dr. Okoro?
I just will say that I'm hopeful, just like Sarah said, that we're making progress. We've made progress thinking about the 15 years that we've been doing this work and how far we've come. And I know that as we continue to talk about it in these different spaces, that we will not have to wait another 15 years before we get to the next level. So I'm really excited about that. So thanks again for the chance to participate in this forum today.
Thank you all. And so now I pulled some questions from the chat that we can address. So has anyone seen any kind of community assessment that somehow elevates community risk assets and then puts population health indicators within that assessment? We know that to be what people need, supports around them. Apologies. Okay, we'll move on to the next question. So are there any movements in PRAMS or BRFIS that allow people who are non-binary or trans to indicate as such? Otherwise, we are stuck in these male-female dichotomies.
I will say that I'm not sure. I know PRAMS is currently going through its phase 9 revamping, but I'm not sure if there are going to be questions. And if there's anybody who is on the panel and or in the audience that are participating in this from their state, maybe that's something they need to bring up as PRAMS is kind of in this phase of revamping. Regarding BRFSS, I'm not sure.
Thank you.
Isn't there some talk about birth certificate changes? I mean, I know they take forever to make, but in there, I mean, because PAMS is based off of birth certificate data, so we would get a little bit maybe if they change the birth certificate, but that's a long process, we know.
And I think in the BRFSS, I never know if I should say BRFS or spell out all the letters, but in that data set, there is an optional module that states can adopt that has additional questions, I think, about gender identity, but I don't believe that currently the core module offers that opportunity, but I think there's an optional module for states.
Thank you all. Another question. So I really appreciated Dr. Okoro's earlier point about using white people as a comparison group for racially marginalized groups. How can we build the conversation to interrogate why we use white people as the baseline and find more meaningful comparisons?
I mean, I will just say that I think that's what we've always done, and it's kind of tradition. And I guess the goal was thinking that it was the standard, and you're trying to make sure that people are meeting up to the standard. Again, as we're learning and growing, we realize that all the other populations are complex in many ways because many are made up of immigrants, refugees, and the definition of race and ethnicity is so much more complicated than we think. So I think that's it. But again, as we're trying to look forward, I think what's interesting and exciting is that we are starting to be mindful of this and trying to make sure that as we talk about a particular group or population, that are we making sure that as we're quote unquote having reference, are we doing it correctly? And do we need to have a reference? Maybe we just display the data as is and let people make their own interpretation versus us feeling the need to interpret everything at all times for people. So I think it's an ongoing thing. It's a hard thing for us as researchers because we want things in a neat box, but maybe that's part of moving forward.
Absolutely. I definitely have seen movement away from using white people as a comparison, not having a comparison across racial groups, but thinking about there's so much heterogeneity within racial groups, as you mentioned, Dr. Okoro. So there's been papers that focus on Black maternal health that are only looking at samples of Black women and Black birthing people. And I think that's important for us to keep in mind. So you've mentioned earlier the variation, African Americans, Caribbean Americans, African immigrants, or African Afro-Indigenous peoples. There's limitations of the data, right? But with what we do have, we can recognize that there's opportunities to look within racial groups for the research that we're conducting. So those are all the questions that I was able to see in the chat. I really want to thank everyone for joining, particularly the panelists, but also the audience for participating in this panel discussion. I know that there are other sessions that will be happening later this afternoon and on the 15th. So with that said, I will turn it over to the conference organizers.
And I want to just say thank you, Isabel, for facilitating this session for us. We really appreciate it. And thanks again to the panelists. Y'all are wonderful. I also do want to note there was a response to your question about the community health assessment that came in the chat, and that Oklahoma has an assessment tool that touches on the topic of whether or not the woman has a support system at home. It's not a community assessment, but it is a start in something that they can collect data on and track to see how many of their clients do or don't have support systems. So that was kind of an interesting alternative. But again, thank you to this wonderful panel. We truly appreciate you all for taking the time. You're wonderful. And stay tuned. We have our next session coming up at 1:30.
Hey everyone, so we'll take a quick break and come back for our next session, which will be reproductive life planning at 1:30. Be sure to check out our Future Forward Jamboard and share any ideas that you have there. Also, make sure to tag us on Instagram, Facebook, and Twitter. We're grateful to all of our speakers for sharing their insights with us. And you can learn more about our speakers and their work in the speaker section of the Conference Hub at beforeandbeyond.org/futureforward. We also want to take some time to thank the UNC School of Social Work for the technical support during these conference days. You can find all the details you need for the conference in that Conference Hub. The registration will stay open if others would like to join later on. And you can also find the Jamboard on the Hub as well. So you can share your inspirations, thoughts, ideas, and challenges for us to review throughout the day. So we'll come back at 1:30 for the next session.
Hello.
Hi, April.
Hey, April.
Hi, how are you?
Good.
Good.
We are just, the other panel just finished, so we're just taking a few minutes break.
And
It sounds like your audio works and everything, so that's good.
you might want a
Yeah,
little
it does.
bit more lighting on your face, on your lovely face.
Yeah, it looks a little fuzzy to me. Does it look fuzzy to you?
Yeah, I can tell that you're there,
Good.
but I'm not seeing as much.
All right, let me see if I can get another light or turn this light on. That makes a difference. Is that better?
That's definitely a little better, yeah.
Okay.
Hi, Meredith. Hi, Debbie.
Hi, good to see you.
Good to see you too. You know, we are live. I just want to say welcome And I think Rio Holiday is on break, but she's our graphic facilitator. And we have Kennedy and Jessica, who are also on a bit of a break, are our hosts for this session, in between sessions. And I'm going to be off camera, but I just wanted to say I'm so excited. Patty, hi. What a timely time to be talking about this. Feel free to say what needs to be said.
Yeah, for sure. Thank you.
And just so that you know, because we're in webinar mode, like those of us off video aren't seen by the participants. So only y'all on video are seen.
And so we're all as panelists staying on video the whole time? Is that the?
Yes. We are all very grateful to you.
Sarah or Catherine, will one of you just monitor the chat during the session?
I'll be glad to.
Thank you. I'll try to look as well, but just in case I start missing stuff.
I was very chatty last time. I'll try to bring it in.
So are we sort of jumping in the middle of, like, participants have been back-to-back sessions, or?
We've got a bit of a break, about 20-minute break between the last session and this session. So people will hopefully be jumping back on in just a few minutes.
We spread it out over several days, so people shouldn't be too. We just had an hour session, so they're not. And
it's not been an all-day Zoom event. Yeah, I think we all had those in the beginning and realized 8 hours on Zoom is not a productive strategy. So trying to break it up.
And then you all go until 2:30. So what will happen is when we get closer to folks coming back, Jessica and Kennedy will jump back on and welcome people back. And then after your session, we'll have the last one at 2:45. So we'll just hopefully tell people to I guess Jessica and Kennedy, but hopefully just ask people just to stay tuned because that's just a really short break. We were up to almost 80 participants for the first session. So I think some people are also kind of coming in. Yes, we can hear you. Hi, Janice. People are coming in also by interest on topic. I wish that we could hear Janice from Alabama and that we were in person because I would love to see you, Janice.
How is the weather for everybody? We kind of got slammed here in our area. Shocking, very shocking in the Philadelphia, Delaware, New Jersey area.
We got lucky in North Carolina. We got some heavy rain overnight, but today it's beautiful. It's like that post, what it looks like after hurricanes here, where everything is just like blue skies, not humid, 75 degrees. It's kind of amazing because it's been 95 and 100% humidity. So we're gonna enjoy this one day. But yeah, yesterday was pretty gross.
I have I was saying earlier, a lot of friends and family in New Jersey that have flooded basements right now. I have a friend that's pretty devastated, their houses.
Yeah, I'm in New Jersey. We're underwater here. My downtown is flooded. And I heard New York City is not holding up so well either.
Yeah, I saw the house in Mullica Hill, New Jersey. I mean, it was like ripped apart. Like the mayor described it as like a bomb going off. I mean, there was nothing left to this house. It was unbelievable.
Oh my goodness.
I feel like this hurricane just kind of came, wasn't on anyone's, I feel like the really big ones that everybody watches every minute, you know, that start off at 5s and then they, by the time they hit, they're a lot smaller and they tend to get all the attention. These that kind of start smaller and then they just build. But I'm really surprised to hear about that devastation up there as well. And I'm sorry, Meredith, your town is underwater. Feeling for all the people that needed to use the subways, feeling for all the people that are trying to shelter with the pandemic.
You guys see the question about the timing of the session?
Mm-hmm. Yeah. And I think that we have a lot of activity on social media, right, Suzanne?
I'm getting like the notifications like we have a sign on and somewhere else in North Carolina. So that's fun. Different areas of the state and country. Hi, Dan.
Good afternoon. Can you hear me okay? Great. All right. Cross that technological hurdle. Check.
Thanks you guys for joining us. I think we have the whole panel. Yay.
Yeah, no one's flights were delayed. I think we've been reminding ourselves that, you know, there are tricky things with conferences, whether they're virtual or in person, right? At least this way, no one will tell us the food was bad.
I look forward to the next time we get together.
We won't even care how bad the food is.
No, we won't.
Everybody, this is Jessica, if you haven't had a chance to meet her.
Hi, it's great to meet you. Meet you all. New faces that just logged back on.
For the organizers, are you guys okay if we rename ourselves and add our pronouns to our?
Absolutely.
I need to do that as well.
Guys, I do.
So I actually don't know how to do that. How do you do it?
You click the three buttons and then the bottom option is rename.
Which one?
So in the top of your little
buttons on your
picture,
box.
Hold on. Boy, that was a whole response.
in the top of your picture, there's 3 little dots. Just click on that. And then you should see rename at the bottom of that menu that pops up.
Okay. You have taught me. I've always wondered that. I've never been able to ask.
It's because you don't have like a patient 8-year-old in your house to train you on these things. That's how rest of us learn.
I was gonna say, yeah, it's definitely my 9-year-old who taught me how to do it. So they all got in trouble last year for renaming themselves things they were not supposed to in 3rd grade. So that was a 3rd grade trend.
I will admit, I am teaching in person now, and that's the one thing I missed, is being able to see everyone's names by their faces. So I went back to the old-fashioned little tent cards, brought in crayons, and I'm like, they're like, this is so old-fashioned. I'm like, yes, it's so like current. It's an adaptation from Zoom into person. Anyways, I'm gonna get off camera. It's gonna be a great session.
So Are Kennedy, or you or Jessica going to do any introing before I do, or how does, sorry, or are we just jumping right in?
We'll do a welcome back in about 2 minutes.
Okay.
Just welcoming. I see that some people have logged on and are watching our pre-session answer. I can go ahead and get the first slide up.
So Erin, you can introduce the panelists. So I'll just welcome everyone back and then describe the session and then pass it on to you.
That sounds perfect. Thank you.
And Shamika let me know she's been going live during the sessions and between breaks. So if anyone's on Instagram, been live chatting about what we're hearing. I also have updated the conference hub page. Yesterday's sessions, we had graphic facilitation. We have that also going on today with Rio Holiday. And that conference page now has those images up from yesterday, so people can see the graphic notes. They're pretty cool. And then we also have the Jamboard that's been moved now to the social media section. And then something that I'll also say that this morning there was questions about different reports, like CDC reports. And Erin, I know that this team also sent resources. Those are all up on the conference page under this session, under the agenda where the session is, and under resources. So if anyone has questions asking to link or to cite something, they can head over there to find those different reports and citations. And April, I believe I have your slides up in that section as well.
Thanks, Suzanne.
I'm gonna go off camera.
All right, it's 1:30 on the dot. Are we ready to get started? Awesome. So welcome back. We're ready to begin reproductive life planning, best practices and implications for patient care and program planning. During this session, panelists will describe varied approaches to asking patients about their pregnancy intentions, explore common challenges and opportunities when providing responsive care, discuss potential pitfalls both clinically and programmatically, and share their views of what's on the horizon. Attendees will have the opportunity to ask questions of the panelists and weigh in on future directions in the field. We'll be monitoring the chat and we'll save time for open discussion at the end. Be sure to stick around after the session. We'll be taking a short 15-minute break. So feel free to go to the bathroom, grab a snack, some water, and then we'll dive right into the next session at 2:45. All right, I'll let Erin take it away.
Thank you so much, Jessica. And I am super excited to moderate this panel this afternoon about reproductive life planning. And we have a really fantastic group here today, including April Lyons-Alls, Debbie Stolberg, Meredith Mance, Patty Kaysen, and Dan Frayne. I'm going to let them introduce themselves. They come from a variety of backgrounds, both clinically, research, programmatically. So I'll let them say a few words about themselves and then we will jump into our questions. April, if you want to go first.
Sure. My name is April Lyons-Alls. I'm a registered nurse working as the Women, Infants, and Families Nurse Consultant for Delaware Healthy Mother and IFA Consortium in close partnership with Delaware Division of Public Health In that capacity, I support several initiatives, which includes Black Maternal Health, the Preconception Peer Education Program, which is college-based, and the Well Woman Initiative. My role for the last couple of years has been on developing Every Woman, Every Time Delaware Well Woman Initiative with Delaware Healthy Mother and Infant Consortium. And Every Woman, Every Time Delaware is a community-facing, population-focused initiative. Happy to be here. Thank you.
Thanks so much, April. Dan, do you want to go next?
Yeah, good afternoon. My name is Dan Frayne. I'm a practicing family physician, and I am the kind of family physician that sees the whole spectrum of patients, including obstetrics. I'm also the president of the Mountain Area Health Education Center in Asheville, North Carolina. I've had the pleasure of serving as the co-chair of the clinical working group of the National Preconception Health and Healthcare Initiative and a consultant for this COIN, as well as on the Implicit Network, which is a group of residency programs that are working on intraconception care at well child visits.
Thanks so much, Dan. We couldn't hear you as well at the beginning, but I think when you leaned forward a little bit, we could hear you a lot better. So Debbie, do you want to go next?
Hi, thanks. Debbie Stolberg. I'm also a family physician, and I serve as the chair of the Department of Family Medicine at the University of Chicago. So my research focuses on integrating reproductive health services into primary care, as well as on institutional barriers to high quality comprehensive reproductive care. So I'm bringing both that research lens, but also the lens of a practicing family physician. I see patients at a community health center on the south side of Chicago. And my research in this area has mostly focused on the One Key Question tool. So I'll talk a bit about that. And I also worked with a colleague, Dr. Jennifer Bello-Cottonsteady, who developed a tool called the Reproductive Health Self-Assessment Tool. So that's my research background. Great to be here with you guys.
Okay, we're so glad you're here. Meredith, do you want to go next?
Hi, everyone. I'm Meredith Manzi. I am so happy to be here with this crew, especially on the panel. And I'm from the CUNY School of Public Health in New York in the Community Health and Social Sciences Department. And today I come with my research lens, very similar to Debbie's, focused on the integration and expansion of reproductive health in primary care specifically. And we'll talk a little bit about a series of projects that we did as they relate to some of the panel questions and our discussion today. And I'm excited to get started.
Thanks so much. And last but not least, Patty.
Hi, I'm also in family, but I'm a family nurse practitioner. It seems like we're all family focused for a good reason. And I've practiced in a really wide variety of settings over the last 40 years and primarily focused on sexual and reproductive health, although I have had, a decade of primary care in there. And for the last 10 or 15 years, I've been focusing most of my efforts on training and on education and writing and also in developing the PATH framework, which is a framework for talking about reproductive goals, sexual and reproductive health goals in general with clients and people. And this framework is specifically for all people, so it's not just for women of reproductive age. And I would say in that framework is a combination of conversations about reproductive goals based on questions that are inherent to the framework, but also counseling skills that have been both time honored and also novel combined. So that's hopefully what I'm bringing to the panel today.
Awesome. Well, thank you guys. I really appreciate it. When we've had kind of our initial meeting to talk about this panel, and a couple of notes around language came up. We named it reproductive life planning. Other folks talk about pregnancy intentions. Other folks talk about reproductive goals. And so I was wondering if any of you wanted to weigh in on kind of the language that we use and how we talk about this.
I'm happy to weigh in if it makes sense. And I think everyone on the panel here knows I have a particularly strong perspective when it comes to the language that we use. So for anyone who's not familiar, we historically in the field have referred to pregnancy by intentions, whether or not a pregnancy was intended or planned. And I think in the last probably 5 to 10 years have been realizing that that language is fraught with assumptions about the universality of wanting to and being able to plan a pregnancy, and also prioritizing it as a gold standard, when there is some research that has some methodological, limitations, to suggest maybe planning is associated with some negative health outcomes for the mother and child, but not anything that I would say is definitive or conclusive in terms of causality. And so I think the reason that we have trouble with the language is that we're not exactly sure what this conversation, as we'll talk about today, more in a clinical setting should look like, and therefore have trouble labeling it. I tend to prefer to think about it as sexual and reproductive health service needs for reasons that I'll talk about in a little bit. And I think in this panel, we might have decided to use the term reproductive goals and desires, with the understanding, for me anyway, that it's still not ideal, and it still infers that someone would have had to use some prior thought into determining their goals and their desires.
Yeah, I would underline what Meredith is saying 3 times. I think that the planned pregnancy paradigm is actually really off-putting for people for whom planning is not a part of their regular way of dealing with their lives. Having children and reproducing, starting a family, increasing the size of your family, these aren't inherently medical questions. They're really personal, and they're about being human. So the whole concept of medicalizing it into this ideal of a pregnancy planning paradigm, I see where it came from historically. I do think it does damage, and I also think that it's in the damage that it does, it not only makes it difficult to establish and maintain rapport with patients when you're having conversations around this, it actually, I think, pushes people away from being able to be prepared for a healthy pregnancy, which is really the kind of language we use with the PATH framework. Just the concept that what we want is exactly what Meredith is saying, which is to get people into care, meaning that if they potentially are seeking or are open to pregnancy, or if, and I think this is a much better word, if a pregnancy would be acceptable, and I wish we could just think about pregnancy acceptability, but for that given person for whom pregnancy is acceptable, we would like for them to be on folic acid. We would like to be able to talk to them about any teratogenic medications, et cetera. And that's really the goal, really the only goal, I would say, of the conversation is the services that we would be engaging, that we'd be offering to the patient to engage in. I do think there's a difference between planning and intention. Intention does have a specific desire inherent in it, but planning actually also involves concrete steps that you're putting forward to make the intention happen with a specific timing, both of them with a specific time frame. All of this is problematic because even if you do have the resources to be able to plan and the luxury, if you will, to be able to plan, that doesn't mean that you necessarily want to, or that there's any real inherent value to you in doing that and making your own reproductive choices fit into a plan of a certain kind. So we could go on for a long time about this. The problem with all of this is we don't have better language. So reproductive goals sounds super close to planning, but so I think that's what we're using for now. And as I said, I think the word acceptable is actually probably the most accurate word that we would be able to sort of summarize all of it. Because at the end of the day, whether a pregnancy is acceptable or not is the thing that's going to decide the outcomes.
I think, I'm sorry, Debbie. I just have a quick point. I want to, echo the sentiments of both Meredith and Patty and say, when I am working with women in the community, teens or whatever, they have no idea about that clinical speak, pregnancy intention screening, or reproductive life planning. It's like they're looking at me like, what are you talking about? So I think, having language that meets people where they are, putting it in terms that they can understand, I think with the intention of really trying to foster trusting relationships and establish a real connection and dialogue are the things that are really key. And I think sometimes that gets lost in the lexicon of our language.
Yeah, that's very similar to what I was going to say, April. So thank you. And I'll add to that, like kind of in the clinician-patient relationship, this shouldn't be so different from any other aspect of care, which is what's important to you should be important to me as your provider. And so I sometimes say, you know, goals or wishes or desires. And I think Patty made a great point that, first of all, people's wishes and desires change over time. Sometimes you're excited about a pregnancy and then something changes in your life or with your health, or you learn something about that particular pregnancy that it's no longer a happy situation. Well, I'll just leave it there. But, you know, it's also, I guess, connected to where you are in life with your finances, your school, your job, and so many other things that just kind of trying to align our care with what is important to the patient or client, I think is what this is about at its root.
Well, at the risk of monopolizing this entire conversation, I do want to say that I think we all need to think deeply about what planned pregnancy actually means and implies, because in terms of the United States, at least, I think we have a pretty shared definition of the term of a planned pregnancy, which is that you should have your finances in order. You should be in a mutually committed long-term relationship, usually defined as marriage. These are things that not everybody is going to have in place. And yet, does that mean that those people should not be reproducing? I think this gets to a much deeper societal ill, which is the concept of stratified reproduction, about who should and shouldn't be having babies. So I think we also need to consider the deeply racist and deeply classist assumptions that are built into that.
Thank you. No, those are all great points. I think y'all touched on this a little bit, but I would love if you guys could explore some about, you know, if we are going to ask about this, what's the value, you know, especially in terms of making sure we're framing things, and, you know, what's important to the patient should also be important to us. Why do we ask about this in a clinical setting? Why do we care?
So I'll go ahead and start that one. Is that one of the reasons to recognize is that we haven't been. That once we recognize that we all in the medical fields and in sexual and reproductive health fields and in public health fields, we know that we should be asking and having these conversations. But we also know is that they don't happen regularly. They don't happen in context of medical issues that actually would matter. And so the key concept is that we haven't been routinely asking, and it really does matter in the context of the whole woman care, the whole person care. We have left reproductive and sexual health out of and separated out into a silo. And when it comes to preconception health, and we're talking about language, I know that word is problematic as well. So the idea of being healthy before a pregnancy, nobody owns it. You know, it has not rested in the hands of OBGYN. It has not rested in the hands of routine primary care. It has not rested in the hands of specialty providers who are taking care of people with chronic diseases. And therefore, it is a big gap. And so I think the most important thing that we all need to recognize is that we must do this in order to improve the health of the people we serve.
I think you made some really excellent points, Dr. Frayne. Involving the community early, listening to their concerns and getting feedback is an intentional part of our process. In Delaware, we were really fortunate. We held statewide chat and chew focus groups, and one of the topic areas was around preconception care. And there are a couple of themes that came out very strongly. And the first was women had a real desire for a connection. And the way they described that was being able to speak freely about their deepest concerns, ask questions, offer ideas, and participate in a dialogue. And the second theme that came out was really interesting, was about didactic versus conversational tone in providers. So women had very positive relationships with their doctors and a real appreciation for their competency and efficiency in addressing their concerns during appointments. However, beyond that, there was a desire for a real conversation on how to incorporate recommendations and suggestions into their early lives. And I know providers are really challenged. They have very limited time, but this is something that women share with us that is extremely important to them in this space.
Yeah, I was going to add, you know, in clinical practice, we get measured and incentivized on things. So things like, did you screen for whether someone smokes? And if they smoke, did you counsel them about the benefits of smoking cessation? Or if they have diabetes, how well is their blood sugar controlled? Or did you screen for depression? And if we don't have standard measures and processes for reproductive health, by default, the things that we do measure and get incentivized around will be prioritized. So I want to echo what Dan said, that like there's a lot of important work to be done about how, but we can't pretend that we can ignore it. And one of the toughest balances, I think, is what people sometimes describe as like we don't, you know, not letting the perfect be the enemy of the good, and that balance between, if we're struggling with what's the best way to do this, does that mean that we don't ask at all? And I think, you know, patients often don't have any widespread community level knowledge about the importance of health issues prior to pregnancy, or about medications that could be, you know, harmful when you're pregnant, but are super helpful if you're not pregnant. Things like that there's just a real lack of awareness. And so I think it's on us to raise the topics that are important and to proactively ask about it so that we can identify those needs.
I think it's really important to kind of just highlight that lack of awareness, and I think it goes both ways. There's a lack of awareness on the provider side too, of how important that information is on the decision making. You know, so I've described it as context matters. The context of a woman's reproductive goals, where they are in their current life and thinking, it matters on the decisions being made that may be traditionally felt as irrelevant, but they're not. And that's the thing, is that neither the patient recognize how much that matters, so they don't bring them up, they don't think about it, and that therefore the provider doesn't remember that they matter, and therefore they don't bring it up. And when it does get brought up, so often things change. Different decisions are made, different conversations are discussed. It's a more patient-centered approach to decision making. Everything changes once that context is brought to light.
And one of just the obvious big picture benefits of doing this is that as our access to reproductive health and reproductive rights, I think, you know, is slowly chipped away, or rapidly chipped away, as it were, like as in Texas and access to abortion, the more that we can train, you know, primary care providers, even specialists, and not just talking about these things, but in doing some of these things and being able to provide abortions and administer, you know, contraceptive methods and all of that is just, and, you know, it's an opportunity for expanded access for everybody.
Thank you, guys. That's a great point. One of the things that I know we talked about wanting to touch on, and also has come up in the question and answers, is what do we know about how we should approach this conversation? And are there differences both by types of providers and but also by the patient population? One of the folks in the Q&A brought up, you know, should we expand this beyond, you know, cis-identified women, but should we be talking to all folks about their reproductive desires, plans, goals? And I know, Patty, you touched on that a little bit in the intro about the kind of how the path framework is structured. But I was wondering if y'all could weigh in both from the research side and also the clinical side, kind of what you've seen about how to approach this and how it may differ.
I'll jump in about the, asking anybody the questions. And it goes beyond sort of cis female, cis male. It goes into, of any gender, any sexual orientation. I think that it's pretty clear that while, as Dan's saying, people just don't get asked these questions to begin with, kind of across the board. But then particularly so if they are people that the healthcare provider or the system doesn't think should be having babies, in which case those people are absolutely not asked, deeply not asked, like avoided, because if you bring up the question, then potentially you're starting down a path that you can't, you don't want to go down. I don't want, perhaps the person who has substance use disorder, I don't want to bring this up because this person should not be getting pregnant. I feel very strongly that this person shouldn't be getting pregnant. I'm not going to ask a question around reproductive goals because I don't really actually deeply believe that that my goal in that conversation is to help the person clarify what they want and help them get it. I have an opinion. I don't want them to get pregnant. So I think it goes beyond just gender, but when we address gender, we certainly can look at, for example, Sonia Barrero's research in Pittsburgh, where looking at low-income men's responses in a qualitative research way about reproductive agency. And I think we can pretty intuitively know just from our work as providers that men generally don't experience a lot of reproductive agency. And that's probably in one of the things in some ways undergirded with the good that women are the ones who are getting pregnant and carrying cis women, people with uteri are carrying the pregnancy. So they are the ones who get to make the decisions about that pregnancy. But where does that leave the person who caused the pregnancy? And I think asking about reproductive goals to people that are possibly engaged in sexual contact where a pregnancy could occur is a really important piece of this. Not to mention the fact that vasectomy just doesn't get raised very often in conversations, and it's a highly effective method that many people who have the correct anatomy to get a vasectomy might really love at the end of the day if they had really, they'd had conversations about it with people over years, they understood what it was something that was really in their purview to choose. So, these questions get, it's the question of who to ask and what the benefit of asking is and why we don't ask. These are really broad questions, but I would just throw it out there that my understanding of this is that the wider net we can throw for this in terms of who we ask these questions of, who we engage in these conversations with, the better for our patients and the better for the population too. I have to say on a population level that I think there are also population level benefits for that.
So on the how, I think is the right question. And I would say that we don't know. We don't know what is the best practice. And that's because the research hasn't been done. And I'll just throw it out there that the NIH rejected the concept that this needed to be studied, which Debbie and I I think it told us a lot. Why would the one key question need to be studied? Just ask the question. That was what the response from NIH was. We don't think this is valuable research, which is wrong. And so this is one of those opportunities that it is really important for us to discuss that we don't know how best to ask this. I think we intuitively know what we shouldn't be doing. What we shouldn't be doing is asking things in a way that are close-ended or judgmental or prejudge the response so the idea is that whatever way we do it, it needs to be done in a way that opens a dialogue, that opens a discussion. And there's probably many different ways that we could do that. And it probably depends on the context of when you're asking it, what else is going on, the relationship you have with the patient already, things like that, So I think we have an opportunity to continue to explore many different ways of doing this. But I do think it needs to be explored of what would be the best practice in various settings and various relationships in continuity versus non-continuity, the emergency room versus the primary care provider, which versus the chronic disease provider versus the public health worker. I mean, I think everybody should be asking and having these conversations, but the how could be different.
I can share a little bit about some of the research that we have done to look at this. And for people on the panel who have, like probably sick of hearing me talk about it, feel free to tune me out. With some colleagues at CUNY, we did a series of studies with stakeholders, with patients, male, female, and transgender individuals. And we did a survey with primary care physicians and all in New York State. And then also qualitative interviews and focus groups with, we were only able to get to just women. And the kind of big take home from those series of studies were that both patients and physicians, in terms of the approach and how to do this, preferred an open-ended question. We asked about a few questions, the one key question being one of them, a different question about that we had come up with in our stakeholder meeting. And the one that they had preferred was an open-ended services-based question, which was, can I help you with any reproductive health services today, such as planning for a healthy pregnancy or birth control? And part of the reason that they liked that question, I think, was because it felt non-judgmental. It wasn't just focused on cisgender women. It wasn't just focused on pregnancy. It could open a conversation about, STIs, about a bunch of different things. And I think it also avoided some of the things that April and Patty had referred to in terms of like doctors needing to be able to get involved in patients' decision-making. Someone who is 18 years old or does have a substance use disorder or whatever knows the answer when it knows what to say. If somebody asks them if they want to get pregnant, they know not to say no and not to say yes. But an open-ended question, not that it avoids the conversation, but at least it approaches it, I think, in a way that can feel non-judgmental, and it doesn't feel like there's a right answer. So we're exploring more about, what the follow-up protocol and conversations would look like. But it's one thing that I think there's something there, but I'm biased, obviously.
I'll jump in, and I apologize for some background noise behind me, but for listeners who are maybe new to this, I'll just share what the one key question is and a little bit about that initiative and some of the findings. But I'm going to hone in on that what I think we've learned so far about how we should do this. So the one key question is a tool that was originally developed in the state of Oregon, the Oregon Foundation for Reproductive Health, talking to clinicians and patients. And basically the patients sort of said, what we really want is for someone to just ask us what we want. Why are our doctors not asking us what we want? And so the question that got developed is, in the next year, do you wish to become pregnant, or would you like to become pregnant in the next year? And then to suggest or offer that there's a range of answers. So you could say yes, you could say no, you could say I'm unsure, you could say I'm okay either way. And it's been studied in a couple different ways. Sometimes people have looked at no, but some point in the future, or no, I don't want to become pregnant ever or ever again. So that's the question, and the tool itself and the sort of program around it is now run by the group Power to Decide, and it involves standardized training. I think, Dan, you might be a trained trainer of one key question, which I am not. I've been through the training as part of my research. But one of the hows that I would drive home, one of the lessons about how should we implement if a clinic or a system is going to use one key question, is that training really matters. And I have a couple of different studies, but one, we did sort of a passive prompt where the electronic medical record had a form that included one key question and those different answer options. But the training that providers got was very brief, like a 10-minute as part of a busy provider meeting. one of the, that wasn't totally standardized. So one time it was delivered to the residents, and at the time it sort of focused on make sure you're offering a LARC method as part of your contraceptive counseling, and a different part of the training didn't, so it wasn't standardized. And then in a different study, we used the power to decide sort of standardized training, which includes a lot of content about reproductive coercion and the risk of that, and also about implicit bias. And the issues Patty was talking about clinicians potentially, you know, intentionally or not communicating, I don't think you are someone who should become pregnant. And so the training that now, if you get trained to use one key question that you would now go through, really roots it in a patient-centered framework and, you know, centering the client or patient's own values and wishes. And I can say from our little research, it's not, you know, we haven't done like big randomized controlled trials, although as Dan mentioned, we asked the NIH to pay for one, no luck. But the passive prompt with the very brief non-standard training actually led to, or at least if you compared before and after implementing that, increase rates of contraceptive counseling, but trend downward in patient satisfaction, which is not too surprising if the providers were not doing it in a patient-centered way. Whereas when we implemented it in one primary care practice and one OBGYN practice, and then compared those within the same system to a primary care practice and an OBGYN practice that didn't get the one key question training or didn't implement it, patient satisfaction actually went up significantly in the practices where the providers and staff got trained in one key question. And interestingly, there wasn't as much of an increase in contraceptive counseling, sort of trended upwards, but not surprising that, you know, if you increase your patient-centered focus and you really take the time out to train providers and staff in that focus, that patients will feel better about the care. And I think that is all about opening a conversation. So they've got you let the patient or client know, we're here for this conversation if you want to talk about it, and then you kind of follow their lead.
So to just fill in the blanks with how the PATH framework differs from that a bit, for those of you who aren't aware of it, and again, as Meredith said, everybody can tune me out on the panel because you probably know all of this already. But the PATH framework begins with an open-ended question that's really every word in the questions that are in the PATH framework has been iteratively examined by thousands of clinicians, as well as many more thousands of patients, because it's been used a lot and then discussed a lot over many years. So there's been a sort of it's a very different development process. And it's also not, it is not codified or licensed in any way. The whole way that we have approached this framework is to try to make training materials, job aids, videos available broadly and widely to whomever, and to train trainers, so that really, hopefully, eventually, there will be enough trainers trained across the country that it just becomes embedded in practice, as opposed to having something be a very specific and codified training that you have to go to a particular source to get, and when the materials are limited to the people that have gone through the training. So the first question is for anybody, and it can be used by anybody, any population, any setting, rheumatology practice, substance use disorder clinic, in an emergency room. It can just be used anywhere, which is, do you think you might like to have children at some point? And it's now been put in the guideline for the sexually transmitted infection disease, the new STD treatment guidelines, which are now called the STI treatment guidelines by CDC. It's in the how to take a sexual history portion. It's the question that's about pregnancy prevention. It's actually, it used to be called pregnancy prevention. Now it's called pregnancy intention. So we wanted it to be parenting, but it's pregnancy. But anyway, so it starts with, do you think you might like to have children at some point? And if the person's already had children, do you think you might like to have more children at some point? So same question for everybody. The only difference is if they've had children already, you put in more. And again, that can be used, transgender, any sexual orientation, any ethnicity, it has been translated into Spanish, not as a direct like word for word translation, although it is word for word translation, but it's really been vetted by several different translators to try to get at the heart of the nuance of it, because each of the parts of the question have direct meaning in terms of ambiguity and in terms of hoping that the person will know exactly what we're asking as it applies to, and that they can interpret what that means for them personally, so that we're not leading the witness in any way, but that we're also keeping the question quite directly related to their goals, desires, thoughts, hopes, dreams about reproduction in particular. The second question's only if the first question wasn't a no. The next question is a timing-based question. We didn't put the timing-based question in to begin with. It's the second question, and it's a potentially second question is, when do you think that might be? So about a third of people in one research study defined that as a specific time, days, months, weeks, years. A third in terms of a life event, getting out of school, being married, and many, another third combined the two in some way. When I'm in my 30s, after I've gotten a job. By the way, many adolescents answer when I'm in my 30s. Many adolescents of privilege, especially when I'm in my 30s, very common one. And then about 10% answer with something else. And then there's a very, very important last question, which is the age and path for how important. So the first is parenting or pregnancy attitudes. That's the PA of path. T is the T in path, PAT, is timing, a timing-based question. And then the H is how important is it to you to prevent pregnancy? You would put something before that, like, I don't want to make any assumptions, but if you're having sex with anybody with whom a pregnancy could occur, how important is it to you to prevent pregnancy? And then it's either until then, or you fill in the blank with what they've said previously. The whole thing is extremely quick. And it's designed to be getting a lot of information so that you can then go to the next questions, which would be, since you've said such and such, would you like to talk about ways to be prepared for a healthy pregnancy? Or since you've said, and then you fill in with what they've said, would you like to talk about contraception? And then you would go right to, can you tell me something that's important to you about your contraception? So that's the cliff notes for the questions. And you wouldn't ask all the questions of everybody. You start with the first one and then you go from there. So if they say, do you think you might like to have children at some point? And they say, absolutely, yes, we're trying now. So would you like to talk about ways to be prepared for healthy pregnancy? Those would be the entire path questions in that context, for example. Sorry to bore you all.
No, thank you for sharing. This is, I think, super helpful, because I think, yeah, there's lots of different ways to get to this information. And, I think it's what people are comfortable using and how they use it. And like you said, the recognition of bias and reproductive justice and equity that they bring to it, that seems to make a difference in how folks respond.
Can I jump in with one more thing, Erin? One thing I really want to emphasize about Meredith's work and the idea of asking a patient, would you like to talk about this today, is something that I often talk about as a pitfall. So you asked earlier about sort of the values and the pitfalls. And I think one pitfall we really have to recognize, especially in primary care, is the risk of, I call it agenda hijacking for the visit, or basically deprioritizing what the patient came in for. And as much as we do have major access problems with reproductive health, we also have access to primary care problems. And if someone is like, my left arm has been killing me for a month, and you've already asked me about whether I smoke and if I'm depressed, and now you want to talk about if I want to get pregnant, like, my arm is what I'm here for. And I think it's only respectful to the patient to sort of offer, like, so, we're here if you want to talk about sex, reproduction, and pregnancy, but also, like, if you say no, that's okay. And really that balance between letting the patient or client know, like, this is something okay to talk about too, but also we don't have to talk about it today.
Go ahead, Dan.
Well, that just highlights another really important aspect that we have learned and have to grapple with, is that that because in the clinical space, we are driven by a lot of measures that need to be captured in some standardized way, we do run the risk of asking questions that we don't do anything about. And that is probably the worst thing in building a trusting relationship and trying to get sensitive information that will improve care. We ask about weight, we ask about depression, we do screenings, and then we deal with something else. And the same thing is true for this, you know, so if we're going to ask, we better have the ability to actually have a conversation, or at least a way to actually say, okay, this sounds like we need to have more time to talk about. Can we set up another time where we can really focus in on this? It is really critical. You know, when we did our human-centered design approach to kind of redesign how we do screening for reproductive age women in our primary care, recognizing that we want to do them all. We want to do depression, alcohol, substance use, tobacco, domestic violence, sexual and STI, contraception, you know, pregnancy intention. We want to do them all. And how to do that well is that we did a human-centered design where we include patients and we included staff and we included providers, and designed a kind of a tool that combines them all in the standardized format. But the key concept that came out of that is that our patients said, it actually doesn't matter as much about how you're asking, is that what I want is the time to talk about it and a trusting relationship that I know you care and are going to do something and you're going to listen. You know, so that's a real linchpin on whatever we do. We have to recognize that it's about trust, and it's about having the time and to be able to talk, for them to be able to talk, and for us to be able to listen.
I appreciate that so much. The concept of listening being the critical piece of this. I will say that we developed the PATH framework specifically with the goal of facilitating listening by asking questions that are efficient and really focused and non-judgmental and non-stigmatizing. Intent is non-stigmatizing, to facilitate that the person has to stop talking and has to listen to the answers. Because if you don't listen to the answers, you can't know where to go next, right? You don't, it's not a checklist possibility. I'm hopping in to answer the question that was put in the Q&A, which is for the PATH framework, are they intended to be asked by provider or assistant? And I would say, luckily, they are designed to be asked by and adapted to be asked by whomever. And we've done large trainings throughout large systems for home health workers, support nurses, going into the home, in people that have birthing families. We've done also a pretty good train the trainer with social workers in a pretty big network. We've done a couple of those actually. So certainly within the context of, for example, a Planned Parenthood frame that is the typical one where the medical assistant, or whatever the name of the medical assistant in that affiliate is, does a lot of the contraception counseling. They would be the ones to be doing it. In another setting where the provider was the one to be having these conversations, the provider would ask the questions. They don't have to all be asked by the same person. An opener could be started, and then there's communication between the person starting the questions and the next person, who would generally be the provider. So that it's been done all those different ways. And also another really important option we haven't talked about, Dan touched on it with the sort of checklist or the list of questions, but is patient facing, is how to have these kinds of opening conversations, if you will. It's not a conversation, but to open the conversation with something that's patient facing and potentially even interactive. Lisa Caligari has a really robust tool for talking about all reproductive and sexual health issues with veterans at VA, and specifically, these are women. I always am struggling around gender terms right now, but that's specifically for women. And a lot of that is interactive. A lot of that they do without talking to a provider or an assistant or anybody in the facility. And I think one of the goals we have of any of these conversations is for the person to be able to get the information that they need in order to make informed choices about their own reproduction and have those choices be consistent with what they really want. That may not involve any of us at all. It may be that a lot of that could happen with patient surveys and materials and things that they can interact with. Certainly in 2021, one would think that we're technologically getting to the point where we could provide these things for people within our the places where we provide service, but not necessarily having to have a human be the one to be engaging with the patient around it. So there's a lot of other ways to do this, but certainly for the PATH framework, it's not specifically for providers. That was, in honesty, how a lot of it was developed. I'm a healthcare provider, and a lot of it was developed with my peers. And as I was starting to do trainings many years ago, a lot of the adaptations of the framework were with trainers, were with people that were being trained, were with people that went out, used it, came back, gave feedback, and we made alterations. So that's, it is the genesis of it.
Thank you. I think we also had another coin during the preconception coin project in Forsyth County in North Carolina, where it was community health workers and care managers who were serving children under 5, but were working with mothers. And the tool that they, through their human-centered design approach, came up, the front of the tool says, "You matter." That was the thing that meant so much to the folks who they were serving, was a reminder that they also matter, not just their kiddos or not just, everybody else in their household. And then what they were seeking to do is have these initial conversations and kind of pare it down so that when they got into these provider visits that were 15 minutes long and super fast, and they had a list of things they really wanted and the provider really wanted, that they could bring up the pieces and felt prepared to bring up the pieces that were important to them, particularly around reproduction and reproductive health. And so I think that was, but I just loved that the front was purple and sparkly and it said, "You matter." And that meant a lot to folks. So we've really hit a lot of the things that we wanted to talk about. One thing I wanted to ask is, as the pandemic has gone on, I think there are both opportunities and challenges that have arisen, and kind of how has that affected your programs, your research, your clinical interactions, particularly around this topic and having these conversations with folks, or if you're doing research in that world, how has that shifted?
I can say just a little bit. I've been working on a study in Illinois, actually focused on contraceptive counseling by telemedicine. That, of course, is one of the big changes in healthcare with the pandemic, is that we have diversified the ways in which patient and clinician interact. And so pandemic specific, I will say right now, it is one take home is that trying to make system change within clinics or within any program that kind of has its core programming, trying to introduce something new is really hard. So that's been one kind of challenge with the pandemic, is just you have to do the basic business, and you're now telling me that I'm trying to do something new or innovative, so that's a challenge. But with telemedicine, I think, it does help to open up access. Not everything, requires a physical exam or 2 people in the same room. And so there are really, lots of conversations, whether it's contraceptive counseling or screening about reproductive health needs overall, that can be done by phone or by a video interaction. And I'll share a couple of really quick lessons from that. One is that we're finding that the telehealth impact on privacy and confidentiality can go both ways. There are some people who are feeling, I'm in my own room, it's just me, my phone, and my provider, and that is actually more private. I don't have to walk into a clinic. I don't have to get there and have people see me go there. On the other hand, not everybody has a private space and not everybody can share their truth with them and their phone and their space where they are. So we have to figure out a way to make the different modes of access still account for that. Same thing with technology. One of the lessons we've heard is please, policy and payers do not only emphasize video. A phone conversation is actually the right thing for some people. And in fact, that video, the visual of seeing someone's home can actually trigger or aggravate provider bias, and that patients are sensitive to that. And so sometimes just having a conversation, like you don't need the visual. So that was an interesting, and then again, like if you are somewhere where having, you know, Wi-Fi bandwidth or a smartphone or what have you is the challenge, then I think there, you know, having a phone conversation is a little bit lower of a barrier. And then the last thing that I'll just share came up is that access when it comes to language and when it comes to different abilities, we really need to attend to that with telemedicine. Not all telehealth platforms are integrating interpreters in a good way, be they language interpreters, sign language interpreters, and also not every client, you know, it works for their brain and their learning and their communication style to interact with a clinician that way. So I think it's really pushing us to think about what's right for this patient in this moment, which is hopefully going to be a revolution in our healthcare, although, you know, we'll wait and see.
Thanks for that. April, do you want to yeah, I was going to say, do you want to talk a little bit about some of the innovations you guys have been able to do through this time?
Sure. I just want to make a point based on what Debbie said, and I'm letting myself think about President Biden's really effort to improve infrastructure, not just roads, bridges, and other things, but also human infrastructure. One of the things that came out during the pandemic in our community, Delaware, I mean, we're the second smallest state in the United States. We're not that big, but in certain areas, broadband capacity is a real issue. And in communities that, you know, we worked in, we kind of took it for granted that everybody has a smartphone or they had more than one computer, that everybody had their own computer, can do whatever. And we found out that, in fact, was not true. So we were really lucky. So it was a lot of happy accidents or coincidences in Delaware. We work with one of our major partners, which is the Warehouse. It's a center that, if you could think of a clubhouse on steroids for teens, this would be it. I mean, it has all the bells and whistles, a fully functioning chef-grade kitchen, a dance studio. It has a theater room. We were able to do reproductive life planning for the teens at the Warehouse virtually. And we had started the process in the community. We had our first session. I can remember this very clearly. It was in November of 19, and then around March 17th, it really was close to St. Betty's Day. Don't ask me why I remember that, but we got the shelter in place order. You know, basically everybody had the shelter in place. We were kind of locked down, and a lot of agencies kind of struggle with, you know, what are we going to do? How are we going to continue to deliver services in this environment? And we were very, very fortunate. Like, we were able to leverage some existing programs that we have. So I support the preconception peer education program at the University of Delaware. We were able to utilize those nurses, those young nursing students, rather, to help us come up with a project around virtual reproductive life planning. The teens had already self-selected healthy relationships as something that they wanted to know more about. And we created Healthy Relationships Jeopardy with all of the bells and whistles, with the board that looks just like the Jeopardy board. You can flip the questions and the money turns around, it'll ask a question. It was really cool. You know, what's really great about working with younger people is oh my God, the things that they can do with technology is just amazing. And, you know, we were really able to do some really cool stuff. The kids absolutely loved it. We were able to have some really interesting conversation about all kinds of topics. And at the end, we provided them with a certificate on that segment of reproductive life planning. And it was so popular, you know, they asked us to bring it back. Like, could you bring it back for the rest of the kids here at the Teen Warehouse? So one of the things we're going to do moving forward, we had this really cool opportunity, is to work with the Warehouse to actually launch a junior health ambassador peer preconception peer educator program for teens, so that we could teach them and they can engage other teens in this space around reproductive life planning. So that was one thing that kind of came out of what we were doing in Delaware, and we're really excited about that.
Thanks so much for sharing. We have about 3 minutes. And so I just want to open it up. If anybody has any last thoughts or comments or things they want to make sure that we cover in this session. Thank you to all of you. This is a great session. Sorry.
I have something I could add. If I've tried to do this in under 30 seconds, under a minute. One of the things that's inherent in the framework, the PATH framework, is counseling skills. And as everybody who's ever trained others knows, it's really important to be pithy and memorable and try to do it easily, quickly. We put everything together into something called the information sandwich. And I just wanted to say, if when in doubt, in terms of a how-to, the sandwich is like, the first piece of bread is acknowledge what the person just said to you, right? With either empathy or agreement or validation. Then give a limited amount of patient-centered content that's relevant to that person. Don't give them a pathophysiology lecture, just a limited amount of content, and follow it with a relevant question before you give any more content. It's an information sandwich, just acknowledgement, content, question. I'm gonna stop there, but I just wanted to share that with everybody. Is if we could all just do that a lot more, we may be able to listen better.
Thanks, Beth.
I also think that reproductive life planning can happen in a variety of settings, not just in a clinical practice, to Patty's point. I think that PATH framework has great utility in other areas. I think it's important to be flexible, adapt, and really meet clients where they are, and really make a concerted effort, I think, to have those crucial conversations that patients, and we don't call them patients in the community, we call them clients, but that clients want to have. So I think that's a really important takeaway. And I would also encourage people to go out to our website at dethrives.com. We have a lot of great information on all our strategic initiatives and just a plethora of educational resources around reproductive life planning for women and for teens, and just about anything else you can think about. So I encourage you to go out and check it out.
Thank you.
One thing that we did not discuss is the value of incorporating these types of discussions within the context of pediatric care. And so we don't have time to get into that, but a shout out to my colleagues with the implicit network of incorporating screening and conversations with mothers who bring their children in. It's a great opportunity that is missed, and it is where these conversations can happen. And so that's another level and opportunity that we can leverage to increase access and awareness.
Thank you. Any other final thoughts, Meredith or Debbie?
I'll say the thing that I am focused on for the next, semester or year we're starting a project on trying to determine the patient-centered metrics, like Dan had referred to, that are the best to use in this context in terms of how to measure whether or not this was like a successful conversation or not. And, making sure that, all the usual suspects of was there uptake of certain methods and all of that, we lose that framework and try to, we're going to hear from patients themselves in terms of what they feel like would be indicators of success.
That is exciting work. Can't wait to hear more about that. And Debbie, any last remarks? Nope. All right. Well, thank you guys so much. This has been really lovely, and I really appreciate all of your input and thoughts and discussion around this topic. I think it's been really exciting for everybody. So I will hand it back to our hosts.
All right, everyone. So we're gonna go ahead and take a short 15-minute break. Again, feel free to use the bathroom, stretch, grab a snack, some water, and then we're gonna dive right into our next session at 2:45. See you then.
Thanks.
I just wanted to say welcome, Dr. Boynton Jarrett. I see you are there. Maybe Suzanne, we can jump on in 5 minutes and do a sound check or something.
Absolutely. And then just for those that are sticking around, if you pull up our Twitter, there's basically a live feed of all of this going on Twitter. And we have a lot of different people sharing important messages. Yesterday seemed very Instagram heavy and today seems very Twitter heavy, which is, I think, appropriate. So take a look, say hello. See you in a few.
Hey, I just wanted to say to the tech team, I put a note to you in the chat. If you could take a quick look at that. Thank you. Dr. Boynton Jarrett, I don't know if you're near your video. Hi, this is Sarah. Is this Renee? Yes, hi. Hi, Suzanne. You know, everyone's starting to come back. Get that last fill up. I wish we could see if anyone wants to chat. Curious if you've gone to caffeine At this point of the day, what is the beverage on your desk? So glad everyone is staying with us for the afternoon. Me too, Catherine. That is my beverage. Ah, it can be a, always in, right? Being back in the office, you forget, like, you can't control the thermostat anymore. I like, Shamika, I like how you're like kind of like going back and forth between calf, decaf, calf, decaf. It's great. All about the balance, right? Broccoli, chocolate.
I love that sparkling juice. I know what you're talking about. There's one that's an apple cider vinegar from Trader Joe's. If you like apple cider vinegar, yes, so good. It's acquired though. You have to like.
The watermelon one is good too, but I haven't tried the apple cider one yet.
Apple cider vinegar, it's acquired taste, I will say. So took me a week to start liking it. Now I'm obsessed.
I have to be careful with these because I want another one, but I can't do it. So water it is.
That was me with Diet Cokes. I had to let myself one Diet Coke a day.
I'm so excited at how many participants we've had with us all day. This is so wonderful.
I will say it is also very interesting that yesterday's sessions were so Instagram heavy. There was just a ton of sharing on Instagram. Today's it's shifted to Twitter. So a little less than, I mean, it makes sense given like what we're talking, you know, the type of things we're talking about and the session topics. But interesting. Well, since we're getting started, I will go off camera and put myself on mute.
All right, so speaking of social media, make sure you're using the hashtag Show Your Love Today, hashtag FutureForward21. We'd love to see what you have to say so we can share it and engage with you. So let's go ahead and get started. Next, we are going to begin our final session of the day, applying an equity-focused life course aligned approach to research on preconception health. We will hear from Dr. Renee Boynton-Jarrett as she centers our discussion around an equity-focused approach to our research, collaborations, and programs. Like always, we will be monitoring the chat and will save time for open discussion at the end. So I'll go ahead and kick it to the panel.
Thank you. I'm going to jump in with a quick introduction and say I'm really excited that we have this late-breaking session. When we initially started planning this convening, this is a voice I wanted to have in this space. Dr. Renee Boynton-Jarrett is a pediatrician and a social epidemiologist. She's an associate professor at Boston Medical Center and Boston University School of Medicine. She's the founding director of the Vital Village Network. Vital Village uses a trauma-informed lens to improve community capacity to promote child well-being in Boston and support coalitions nationally through the Now Forum. Her scholarship has focused on early life adversities as life course social determinants of health. And I had a chance to meet Dr. Boynton-Jarrett. We were brought together for a panel as part of a National Institutes of Health, this big ECHO study they have and focus on children's health. And so it was a whole symposium on children's health and preconception. And I was really fascinated about how they were going to make that happen. And when I heard Dr. Boynton-Jarrett's presentation, I wanted everyone else to hear it as well. So with that, I am going to turn that over to you.
Oh, thank you so much. I'm so honored to be here. I love the title of this convening. We do have to think in a forward way about the future. We have to center on equity. And I'm just really excited to be with my village here of folks who are interested in women's wellness. And thank you all for hanging in there. I know it's a lot on Zoom, but I'm excited for our discussion. I don't have any conflicts of interest to disclose, and I hope not to discuss anything unapproved, and I hope to keep to my time limit. But if you can't hear me or for some reason you can't see my slides in presentation mode, let me know because I probably won't. So today I'm going to just kind of talk a little bit about root causes, so thinking about social ecology and how we think about childhood adversities, including structural racism, which is often underemphasized as a childhood adversity. What does that mean as we take a structural integrity approach to our research in terms of how we measure adversity, positive experiences, resilience at multiple levels and across the life course in a comprehensive way? And how can we reimagine research that will really advance our understanding and ability to promote optimal health and wellness for women and for children, and address the gaps to advancing research ethics as well. So beginning with root causes and social ecology, when we think about the life course and we're thinking about ways of optimizing the health and wellness of women, it is so important to look not only at the trajectory of life for women, but also to think in an intergenerational way. And so really understanding the contributions of preconception health and intergenerational patterns of health is fundamental to the research questions we pose and how we come to understand factors that contribute to health of women in adulthood. This begins with thinking about how the preconception period creates and sets up and promotes a healthy or a challenging in utero environment, and the process of perinatal programming. So what impact the exposures within the perinatal environment may have on timing of birth, prematurity, growth, gestational age, growth retardation or growth expansion, and all of the factors that contribute to the strongest start at the beginning of life. How does that indirectly and cumulatively associated with effects as a child grows into adolescence and through childhood? And ultimately, how is that associated with the arc of life in terms of impact on chronic illness, early morbidity, and mortality? And so one thing we know is that consistently early childhood adversities have an impact on a range of health outcomes for women across the life course. So we know that social hardship, socioeconomic status, adverse childhood experiences, which can be a range of factors from child abuse and neglect, emotional abuse, as well as poverty, family turbulence, exposure to a parent who has mental health challenges are commonly understood adverse childhood experiences, but those are a limited number. And adverse childhood experiences also include experiences of injustice and exposure to racism and race-based trauma. And preconception stress are all exposures that we know have an impact. The timing, the type, the severity, duration, and the developmental stage and age of the individual at time of exposure, as well as the cumulative impact of exposures, are also associated. And the hypothalamic pituitary adrenal axis, as well as the hypothalamic pituitary gonadal axis, are both axes associated with the timing and tempo of puberty, menstrual cycle disruption, reduced fertility and miscarriage, are all associated with dysfunction and dysregulation of these axes that are associated with exposure to acute, chronic and severe stressors over the life course. And so when we think about what we know, early life adversities are associated with pubertal tempo and timing. So the severity of childhood sexual abuse has been associated with accelerated onset of menarche. The severity of childhood physical abuse has been associated with delayed menarche. So we can also see these U-shaped associations between type of abuse, severity of abuse, and its impact on our reproductive and health-related cycles. Graded associations between exposure to early childhood physical, sexual, or emotional abuse and reproductive health have been seen across a number of reproductive health outcomes, including uterine leiomyomata, like commonly understood to be fibroids, and endometriosis. And then cumulative exposures, such as the severity of abuse and duration of the exposure, are associated in a dose-response pattern with reproductive health outcomes. So the accumulation of different types of abuse and the severity, as well as its duration in early childhood, middle childhood, and adolescence and adulthood are associated in a dose-response pattern with reproductive health outcomes. So we also see that there are significant buffers. So adversity isn't the only side of the story. Having emotionally supportive relationships in childhood has been seen consistently as a buffer of the impact of early childhood adversities on future reproductive health risk. We also see associations between social hardships in childhood and reduced fecundability in adulthood. Adverse childhood experiences are associated with menstrual cycle disruption, as well as fertility difficulties such as amenorrhea. Adverse childhood experiences have been associated with increased risk for miscarriage, and preconception stress is associated with reduced fertility. Lower levels of education and income have also been modestly associated with reduced fecundability. So we see that social hardships in childhood and adulthood, as well as at different stages of life, are associated with fertility outcomes and risk for miscarriage. When we take a step back and think about the broader picture of what we understand from a population perspective about adverse childhood experiences, the majority of states across the United States have administered some type of measure of adverse childhood experiences between 2009 and 2018. And in a study led by the CDC, kind of accumulating all of that data across, that over a decade period of time, that nearly a decade period of time, they found several common patterns. So one, the prevalence of adversity and reported adversity in childhood among adults was fairly high and fairly common across the population. However, higher adverse childhood experience exposures were reported by participants who identified as Black, Hispanic, or multiracial in comparison to those who identified as white. Those with less high school education and those with incomes less than $15,000 per year also had higher relative reporting of adverse childhood experiences versus those with higher income. And those who identified as gay, lesbian, or bisexual in comparison to those who identified as heterosexual also had a higher risk for reporting of childhood adversities. So we find that consistently, while adverse childhood experiences are globally quite common, consistently, if in any way you are socially marginalized due to your race, ethnicity, your social class or status, your sexuality or sexual identification, we see consistently risk for higher exposure to ACEs among those who are socially marginalized. So this is really important to how we begin to think about research that is seeking to understand the impact of early childhood adversities on life course health outcomes. Why would early adversities cast such a long shadow, and what would predict some of the differences in the patterns we see? So it is clear that adverse childhood experiences are prevalent throughout the population. That is really important to understand, and really important to understand that across all socio-demographic groups, we see a prevalence of adverse childhood experiences. At the same time, we are also seeing differential risk, and differential risk is influenced by social conditions as well as structural conditions. So structural conditions of neighborhood and area poverty, social conditions such as discrimination and bias that would impact your social treatment are also associated with a higher degree of a higher degree of risk for adversity in early childhood. So when we look at inequities in health and education, economic and social outcomes, we have to take this broader picture into effect. And that can really help drive the way in which we identify and address social programming and work to dismantle structural conditions such as racism. So it's really important that we think about intersectionality as we approach and try to understand these research questions, because it isn't simply these factors, identity factors acting independently, but within a person, they are combined. So your age, your race, your sexuality, or your disability or ability status are all combined. So ableism, racism, sexism, classism are interacting in a cumulative way to impact your risk for experience of adversities, as well as your access to buffers, resources, and supports. So this really requires that we start to think a little bit differently about how we even consider the measurement of adverse childhood experiences and health outcomes, how we consider the measurement and the balance of measurement with positive experiences and resilience to truly understand factors that are predictive of health outcomes and health trajectory. So as a pediatrician and a kind of a public health person who focuses on early childhood and early childhood experiences, many of you may be aware of Bronford-Brenner's model of these nested systems. So the individual nested within their family, school, their social community, nested within their greater group of social structures and policies, all the way up. And so these levels are not fully independent. They're actually constantly interacting. And so when we think about an individual, we think about them developing in the context of this greater social world and these levels interacting. But we also have to think about the ways in which other factors, such as structural racism, also exist within those systems. So Barbara Reskin describes racism as a race discrimination system. So she talks about the ways in which discrimination can be reinforced by the labor market, criminal justice system, healthcare system, school system at the same time. So if we're only looking at one element, one piece of that system, or only trying to change structural racism at one piece of that system, it actually can be very difficult to sustain those changes, because there are other aspects of these interconnected systems, such as residential segregation or school segregation or educational access and attainment, that may be reinforcing the very thing you're trying to change. So it's really important that we also take that systems view when we're trying to understand from a research perspective how racism may impact health over time. So we really have to think about structural racism in two ways, both the interconnections, so the ways in which interconnected institutions may reinforce each other. So changing an individual policy can be less effective for sustained process, but also the ideologies. What are the mindsets, frameworks, and belief systems that may reinforce racial hierarchy or privilege? How power and resources are distributed. And so these are all really important for us to think about at the same time as we think about how we might measure racism and capture its impact on health. So when we think about a structural integrity approach to our research, we're really good at now understanding that preconception health is related to child health risk, which is related to adult health risk. And we are seeing that life course, and we're seeing social determinants of health like adverse childhood experiences, poverty, racism, as contributing to those inequities in health. A structural integrity approach for research takes a step backwards and then really tries to think about the social structures, whether they're economic systems, policies, or structural and social hierarchies that drive the social determinants of health. So what are the economic systems that create risk for poverty? And how might that help us understand who might be at risk for adverse health outcomes? We also need to think in a different way about resilience. So resilience is often centered on the individual, active coping strategies, hope, optimism, faith, very strongly individual characteristics. And culturally, we understand and appreciate resilience at an individual level. Often, when we're seeking to measure resilience in our research, we're also doing that at an individual level. But it's important to really think about resilience as existing at multiple levels as we would in any other kind of social ecological model. So household level resilience might be a sense of belonging, flexibility, high quality care, routines, problem solving, social cohesion. At the community level, it might include safety, prosperity, social connections that are stable, opportunity structures. And at societal level, it might be equitable and diverse communities, social justice, access to healthcare and insurance, our laws, our policies, and our programs. So it's really important that when we're thinking about measuring resilience, we also don't limit to just an individual level of capturing resilience, but also seek out assets and resilience factors that exist at multiple levels within society that may be amenable to change, that can change trajectories and impact health outcomes. So often when we're thinking about a pathway between early childhood adversities and later health outcomes, we might see resilience as a shield, right? And what are the factors that can modify that shield to make it bigger, to make it larger, and ultimately reduce stressors? So when we think about modifiable resilience factors that we are aware of through research in early childhood, parenting, social support, the mental health of caregivers, self-care skills and routines, and understanding of trauma are all critical resilience factors that are amenable to change. But notice, none of these modifiable resilience factors that we have evidence for actually exist at the individual level. These are all factors that exist in relationship, the relationship between a child and a caregiver and the child and their greater social ecology. So actually, when we look at the resilience research, we actually find evidence that resilience and modifiable resilience factors that we can change, grow, and utilize to protect and promote optimal health are actually existing at those interactive levels of social ecology. And so as we think about a child progressing from childhood to adulthood and ways to reduce risk for negative health outcomes, we really do have to think more broadly about the social ecology and network of relations that surround the child. And there are studies, so studies of resilient youth, so 489 African-American youth in rural Georgia were followed longitudinally for 15 years, so followed from adolescence into adulthood. And at the age of 20, the lower income college students had higher obesity, blood pressure, and stress biomarkers than their affluent peers. But they also had higher stress biomarkers, obesity, and blood pressure than their low-income peers who did not attend college. So we see that these resilient youth who achieved and kind of rose from their circumstances and attended college had a physiological cost to that. And so it's very important that we also learn from these studies that the failure to transform and change in social environments to promote the success of all children really can come at a cost in terms of chronic health. We also see that positive childhood experiences that promote health. So there's now more measurement of positive childhood experiences, but we are also seeing differences in access to mentors for advice or guidance, living in a safe neighborhood, and living in a supportive neighborhood among non-Hispanic Black children in comparison to non-Hispanic white children. So this is really challenging data because we're seeing that children who are socially marginalized in society might have a greater risk of exposure to adversities, but also have a reduced exposure to positive experiences that can promote optimal health outcomes. An important caveat to this is, how do we define positive childhood experiences? And are we thinking about those and defining those research measures for positive childhood experiences that consider the gamut of cultural experiences that may vastly differ among different cultural, ethnic, and religious groups? So it is really important to have a broad set of worldviews defining what counts as a positive childhood experience, or we might consistently see differences in lower levels among children that are not white, but is that because we are measuring a limited range of positive childhood experiences? So it's an important question. There is limited to no investigation of positive racial socialization or positive racial identity formation, which for a child of color may be an extremely protective, positive childhood experience that we're simply not measuring because it hasn't been prioritized. This also comes into play when we're thinking particularly about models for women's reproductive health. So for example, Sojourner syndrome, which was a framework authored by the late Leith Mullings, really focused on intersectionality and the intersectional identities of women of color, their social class, their gender, their sexuality, and how that influenced birth outcomes. So it was a much broader consideration of the factors that could influence birth outcomes that really captured that intersectionality. So similarly, like an extension of the weathering hypothesis of thinking about how chronic and cumulative experiences that you may disproportionately face based on race, class, and gender could influence birth outcomes, and considering those in a more holistic framework. So it's also important that we have research frameworks that help us to consider these multiple layers of identity and how they can affect both assets and positive experiences as well as risk factors. So as we strive to begin to reimagine research and really think about how we might address gaps in research and advance research ethics, I think we've seen many statements now, but a statement from the CDC, statement from the NIH that are now acknowledging racism as a serious public threat that directly affects well-being. So this is good. How do we see racism impacting health? We know racism is endemic, so it can impact actually all domains of life. We know that racism can be embodied, so your stress response, your physical health, your mental health, your immune system can all be impacted by racism. And we also know that racism is structural. So policies, systems, and ideologies, whether it's residential segregation or another type of set of policies that are driven by ideologies of white supremacy, can impact health over time. So how do we outcome to then begin to measure this, right? And so let's think about it from a perception, the preconception health model. So infertility, we might define as the inability to conceive after 12 months of unprotected sexual intercourse. The estimated 12% of women in the US experience infertility. Preconception stress and childhood adversities have been associated with fertility and infertility. Self-report of infertility is twice as high in Black women compared to white women in the US. And Black women are approximately 50% less likely to receive and or seek treatment for infertility. Yet we have no published studies of the impact of racism on fertility. So this is an example that's kind of glaring for us, right? In terms of, we can see all of the inequities in the data we have, but there's actually no research agenda that is directly addressing or trying to understand this. And so what happens when we simply present inequities outside of context, like what I just did? I just presented that Black women are 50% less likely to seek or receive treatment for infertility, and self-reported infertility is twice as high. So I just presented two statistics about infertility and women of color with no context. What happens when we present that information? What do we hope happens and what actually happens? Well, what happens when information is presented outside of context is we tend to naturalize it. We just tend to assume these differences are the status quo and can't be changed. Or we see disparities or inequities in so many areas, we just assume they're intractable, they're durable, and don't devote attention to actually exploring why, which we saw happen with our fertility research, right? We assume that this is just endemic. So even when we see alarmingly, grossly disproportionate outcomes, it doesn't elicit concern. It actually reinforces maybe what we think is going on, the status quo, just how things are. And then there's a lack of a personal stake, right? It just simply is not a research question of interest. And why might that be the case? So this is hard to face as a researcher, but I think if we really think about it, what data surprises you and what data doesn't? And it really affects the way in which we tell stories of research with our data. So often we measure race very commonly in our research at the individual level. But what does the measure of individual race really capture? It's not a good measure of culture. It's a poor measure of genetics. It's not a good measure of social class because racial groups can be overrepresented in social classes, but they're usually not the majority of those groups. So what are we really measuring when we measure race? And what is it that we're hoping to capture? And the question is, what responsibility do we have as researchers? So I would propose that we have three primary responsibilities. First, we have to decide if we will or will not collect data about race and state why or why not. So race should not be a default collected data. We've decided race is a social variable, right? Social construct, not biological. So why would we collect it? So have a rationale for why you'd collect data on race. Define it. If you will collect quote unquote race data, why? What's your hypothesis? How might you utilize that data? And it might be because you think even if a poor proxy, it is somewhat of a proxy for a social factor of interest. But describe that so we can adequately describe our limitations as well. So describe, be explicit about whether or not you're even going to try to understand race-associated differences. And if not, explain in your limitations, right? So here's an opportunity for us. I think all of us can go back to papers that we've written and do more descriptive work, do more description of limitations, do more setting up of the context, and do more outlining. You know, we have the data that racism is rarely discussed in research studies. It's more common over the past year or two, but it's been limited in its discussion. So this is an exercise all of us can do, right? And what would it mean if we did that additional work? So structural integrity really asks us to not simply report race-related findings, explicitly state our hypotheses, be explicit and clear about the implications and limitations of our decision, propose future studies and future study designs, and then develop equitable partnerships with communities and creative leadership pathways so new research questions can come to the table, new ideas about ways of measuring and capturing racism and the experiences associated with it. So as we think about research gaps in structural racism, it's really important that we begin to explore mechanisms through which structural racism and structural inequities contribute to the pattern of exposure to early childhood adversity. We can see it happening, but we don't exactly know all of the pathways. So if we want to interrupt those, it's important to measure it. We have to appreciate that we have a limited understanding of race-based trauma and childhood adversities, and we have to expand our ability to measure race-based trauma as a childhood adversity. And then we have to appreciate that racial inequities are documented, but there have been limited investigation of racism. So there's just so much more we can do to balance out the scales. We also have to expand the ways in which we measure resilience and adaptive stress as we're exploring and deepening our understanding of early life adversity and early life stress. There's so many opportunities to prioritize and develop validated measures, to incorporate new perspectives, to involve women of color and Indigenous women in setting the research agenda and priorities, as well as to increase the novel studies preconception period that engage diverse populations. So it's been a privilege to join with you all today, and thank you for the opportunity.
So now do y'all see why I was really excited? I mean, talk about a masterclass on how we really should approach research. So Kennedy, I want to offer you any chance you want to respond to anything with that amazing presentation?
There was so much rich content in there. I just want to say thank you for sharing all of that with us, for urging us to think more critically about some of the assumptions we make in research, and when we're conducting it, when we're interpreting it, when we're sharing it, all of those really important things. And I invite you to stay with us and continue the conversation. We have back to you, Sarah.
Oh no, this is just a conversation. I also think, hi Jessica, I love the life course approach too, because I think that it's a way so that we also get connected on, I do child studies and I do this studies and I do that studies. And I loved the opening slide where you just show it's kind of this whole continuum, and then how well I age influences how well my kids age, right? And how much they take care of me and my mom. And I think that that's just a really great perspective. So I'm gonna turn it to the team. I don't know, Dr. Boytinger, what your afternoon looks like, but we are going to be being able to go to a conversation space after this. So if you have time to join us over there, that would be amazing. But thank you again, and I'm turning it to Kennedy and Jessica.
Thank you all so very much.
So there's some exciting happenings in our Show Your Love work, and we are listening to thousands of people across the country to help understand preconception health knowledge, behaviors, and inform our approach to wellness. I'd love it if Catherine and Suzanne could share a little bit about some upcoming launches that are happening.
Great. Well, first of all, thank you again to all of the speakers today. This was so insightful, so much great takeaways and action charges for us to consider. In the chat, I'm going to put our evaluation for this entire day for this session too. Please do take some time to give us feedback on what you thought about today's session. As Kennedy and Jessica noted, we have our final day on September 15th. It begins again at noon Eastern time, and you can go to that conference hub to see the full agenda and program for the day. I'm particularly excited for the period doctor. If you're not following her on Instagram and Twitter, she just posted some more awesome videos about patient advocacy this week, so please go ahead and follow her. Catherine, did you want to share anything about our Coin and Show Your Love work?
Sure. We're really excited as we're working through our COIN project. We're going to be working on some patient-facing resources that will be available in the coming months. Please do check out our website. We'll have those available online. And if you haven't already, sign up for our newsletter so that you can be aware when those are available. We'll also be sending out information about the recordings. And that will be information will be shared through our newsletter. We also have a webinar series that's going on now, and we can put the link in the chat for information about that. But we do have an event coming up next week if you're interested, that is focused on disparities in fertility. So I think that's it for now. Am I leaving anything out, Suzanne?
We are about to move. We are opening up right now a breakout discussion Zoom room. I'm going to copy the link. I'm going to put that in the chat. So let's keep this conversation going. This is an opportunity for everyone that's attended today. I see that there's 60 plus of us together to gather in a Zoom room where we can all be on or off camera and continue these conversations.
And a big thank you to Jessica and Kennedy for guiding the way today. Dream team.
Amazing.
Thank you to all of our panelists. So we'll see you on the 15th and hopefully see you in a few minutes in the Zoom room. Thanks, everybody.
Thanks so much.
Thanks.
I'll stick around here just so everyone can keep that Zoom link. So I'll see you there.
Bye, everyone.
All right, join us now. All right, we'll see you over in the Zoom room, everyone. Thank you so much.